of quality of life for persons living with sickle cell disease. It is within this context that symposiums such as these that seeks to explore as well as to educate colleagues in terms of the determinants of pain and how to improve pain management is indeed quite welcome. So taken together, I would just like to thank you again for deciding to spend some aspect of your Sunday with us, and hope that you'll find the sessions very rewarding and beneficial, and that you will glean some nugget of information that will improve your own personal management or your own experience in dealing with individuals who are living with sickle cell disease. Again, welcome.
Thank you, Professor Zasnania and Reed, for your welcomes. I would now like to invite Dr. Angela Rankin-Mullings to lead us in a word of prayer before starting our presentations today.
Good morning, colleagues. Let us pray. Almighty God, we stand in awe of you. Thank you for giving us the opportunity to share with each other in this symposium. Please be with the organizers, all participants, presenters, and panelists. We ask that you bless these proceedings so that further information on pain in sickle cell disease and mental health and wellness can be imparted in such a way as to increase understanding in these areas and ultimately to help improve and enrich the lives of our patients and their families. Bless us as we learn together. We invite you to be present among us by the power of your Holy Spirit. Amen.
Amen. Thank you, Dr. Rankin-Mullings. Our first talk will be delivered today by Dr. Mark A. Ware. Dr. Ware is a family physician and currently serves as the director of the interdisciplinary Allen Edwards Pain Management Unit, based at the Montreal General Hospital of the McGill University Health Center, MUHC. He is an associate professor of family medicine at McGill University and holds the endowed Allen Edwards Chair in Clinical Pain. Dr. Ware received his medical degree from the University of the West Indies in 1992. After postgraduate training in internal medicine and research on the painful crisis of sickle cell disease in Jamaica, he completed an MSc in epidemiology at the London School of Hygiene and Tropical Medicine in 1999. He then moved to Montreal as a research assistant and practiced pain management at the MUHC from 2001 to 2018, attaining the rank of tenured associate professor at McGill. His primary research interest was evaluating the safety and efficacy of cannabis in pain management and developing large cohorts of pain patients to identify patterns of care and risk factors for response to treatment. He was a co-founder of the nonprofit Canadian Consortium for the Investigation of Cannabinoids and served as executive director from 2007 to 2018. He has advised the Canadian federal government on cannabis policy since 2001. In 2016, he served as the vice chair of the Federal Task Force on the legalization and regulation of cannabis in Canada. The report became Canadian law as the Cannabis Act in October 2018. From 2018 to 2022, Dr. Ware served as Chief Medical Officer of Canopy Growth Corporation. In this capacity, he helped establish the company's global medical division and led the teams responsible for the supply and regulatory documentation, clinical development, medical affairs, and global product safety. Thank you for being here with us today, Dr. Ware.
It's my pleasure. I hope you can all hear me okay. Monica, Nikki, Leslie, thank you very much for the honor of inviting me to open this fascinating day of sessions on sickle cell pain. This is a very meaningful presentation for me on many levels. One is It's Labor Day here in Canada. I'm calling in from Montreal, where it's a gorgeous day and it's a holiday weekend. Significantly, it's also my 29th wedding anniversary. So I'd like to shout out to my partner who's given me leave to be with you all today, and we will celebrate our partnership together later. It's also very meaningful because, as you heard from the bio, I first got my interest in pain from my experience at the sickle cell unit in Kingston. And it was there that I began to form this idea that there were alternative strategies for managing acute pain, but also becoming aware of the challenges with patients who weren't just experiencing repeated acute pain episodes, but were living and presenting with chronic pain. And this became a journey for me over the last 25 years. And I'm very pleased to share with you some of my experiences, and you'll go into much more detail during the day on the specifics of sickle cell pain. But allow me to take a bit of a step back and set the stage for you in the best way that I know how, looking back over the last 20 years at what we've learned about essentially the mechanics and the anatomy and physiology of the experience of pain. Lastly, it's a meaningful experience for me to be speaking here today because I recall as a medical student being taught an incredible approach to understanding pain. We were shown and given.
Hi, Doc. I'm sorry to interrupt you.
Yes,
Is
ma'am.
your PowerPoint? Are you sharing your PowerPoint? We're not seeing it
Not yet.
Okay. Oh, sorry. Thank you.
That's all right. Thank you. I was just about to bring up that first slide. You can see that okay?
Yeah. Yeah. Very good.
It is the idea that as we were learning about disease management and diagnoses as medical students, we were taught an approach to pain that was extremely detailed. We were taught an alphabet soup of approaches looking at the onset. I remember the OPQRST tools. We were given tremendous training in how to understand pain, its radiation, alleviating qualities, quality, etc., which helped us understand the pathology of what was happening inside the patient. And sometimes we even elicited pain. You recall the diagnosis of acute appendicitis, eliciting pain in a particular area. Pain was a very important part for us as students in understanding what was going on inside the patient. What I've learned over the last 25 years is that pain can become something else. It's no longer just a tool or a signpost to what is underneath the underlying pathology, but there's also an experience of pain which becomes more than just a symptom. And it's that focus that I'd like to take today. Essentially, if I can leave you with this concept that chronic pain actually deserves to be treated as its own disease in the same way we treat diabetes, in the same way we treat hypertension, other chronic diseases. Chronic pain really now deserves to be considered in the same way. And that changes the way we think about patients living and presenting to us with chronic pain. To support this, I'd like to talk briefly about how we've evolved our understanding of chronic pain, talk a little bit about some of the core principles of managing chronic pain, and then, if I may, share a few thoughts and reflections on where I see the management of chronic pain going from my perspective here in Montreal. This is classically how we've always been taught about what pain is. It's a linear pathway. It begins with the site of injury. It involves the transmission of the nociceptive insult or the nociceptive signal through the spinal cord up to the brain where we perceive the sensation of pain. And this classical pathway has been relatively unchallenged for many, many years until the 1960s, when it started to become recognized by a partnership between a McGill researcher and a researcher from England, Patrick Wall and Ronald Melzack, who started to recognize that there were controlling systems along the pathway where the pain signal could be interrupted or modified or modulated. And recognizing that this one-way pathway is no longer the true picture of chronic pain is one of the key steps in recognizing how we have to approach our treatment of chronic pain. Essentially, from the picture, you can see the site of injury. This poor chap has injured his foot. He's activated a pair of nociceptors, one an unmyelinated C fiber, which takes the first phase of the pain signal immediately to his brain, and the second, a slower, fast myelinated A fiber, which takes a different characteristic of the pain in a much slower way, in a much faster way than the C fibers up to the brain. So you have this biphasic pain response, and you can see that in the spinal cord, it crosses over and rises up into the brain. But if we take each level of this pain pathway, we recognize that in fact the complexities begin to emerge even at the very periphery. This is from 22 years ago, when it was first recognized that not only did primary afferent nociceptors, the nerves specifically responsible for the detection of pain stimuli, respond not only to chemical stimuli, but also ionic ligands, as well as inflammatory mediators. And at the same time as they were responding to this soup of inflammatory compounds intended to provide some healing, there was also the possibility that the nerves themselves could release compounds like substance P, so-called neurogenic inflammation, giving rise to the idea that the nerves weren't just a one-way receptacle for signals, but they could actually also generate their own transmitters, which could then enhance and expand the inflammatory response. So even at the peripheral site, you have a bidirectional neuronal interaction with the pain signaling compounds, as well as the release of compounds from the nerve endings that could enhance and worsen inflammation. And then now the number of specific receptors, the number of specific nerve terminals that respond to different types of pain, whether it be heat, cold, minty pain, capsaicin, chili pepper pain, all of these individual molecules have been now cloned and identified in terms of receptors and specific pathways at the very periphery. The story doesn't get much more simple when we reach the spinal cord level, where these now unmyelinated and myelinated pain nociceptors reach the spinal cord and branch in different laminae of the dorsal horn of the spinal cord, and then begin their synaptic journey across the spinal cord and up to the midbrain. Even at this level, you see now the emergence of descending pathways. And from this diagram, you can see that there are descending inhibitory pathways coming down from the brain, which appear to now control those incoming signals at the dorsal horn level. This has given rise to a number of novel pharmacological approaches that you'll be hearing about later. But it also suggests that this incoming pain signal is susceptible to descending inputs from the brain, and not just a linear ascending pathway as we saw earlier. The story again gets complex when we reach the brain, and over the last 20 years now, it's become very clear that that pain signal that reaches the brain from the periphery, passing through the dorsal horn, now starts to distribute itself out into a wide range of brain structures, not just the sensory cortex, where we experience the actual physical location of the pain, but other important areas associated with memory, with movement, with mood, and the pain therefore takes on a very multidimensional characteristic. You can think only of the emotional reaction if you accidentally hit yourself with a hammer, or you accidentally injure yourself. There's the experience of pain, but there's also the frustration of actually having done that, the feeling of, why am I so stupid? I hit myself with a hammer. This emotional reaction happens very, very rapidly, and is something which helps us to perceive and remember that pain is something we want to avoid. But it's also important when we think of pain establishing itself as a disease, this emotional regulation can become faulty. But we can also see that this transmission of pain and the regulation of pain in different brain structures can also be influenced by a number of different types of therapy, and we'll be discussing some of these later. The other thing you can see, of course, from this graphic is, again, those bidirectional arrows. You start to see inputs coming into the pain pathway from the brain, from the cortex, from the cerebellum, descending down into the pathways where the brain pain signals are coming up. And this also serves as a top-down control and modulation of pain. So at every level of the pain pathway, we have both ascending and descending control of pain, each one controlled by different different mediators, by different receptors, by different pathways, but leading to a very complex bidirectional system. And that ultimately gives us the tools to understand how chronic pain can become so challenging to manage. So what then is chronic pain? Acute pain we've studied, we've looked at, we understand, we use this as a tool to understand what we're doing to treat our patients. Chronic pain has been defined as a pain that persists for longer than 3 months. And this is typically chosen because it's the period by which you would expect normal tissue damage to have healed or repaired. And that means that the pain is now persisting beyond the period of time that it would serve any really important purpose. It's no longer telling us that something's wrong. Now the pain is taking on a life of its own, if you will. And as they say this is the International Association for the Study of Pain, a worldwide organization that is celebrating a major anniversary next year in understanding the study of pain. But they recognize now that this pain can persist longer than the period of healing. And as they point out here, it can become the sole or predominant clinical problem, patients presenting only with chronic pain. And therefore, it requires its own specific strategies. And I'll talk through some of those evolving strategies in a few moments. We estimate that chronic pain, by the best tools available, and it's become difficult to define pain and depends on how it's measured epidemiologically, but the best estimates suggest that about 20% of people worldwide in both developing and developed countries live with pain on a daily or near daily basis. It's been described in North America as a public health crisis. And as we'll hear later, some of our approaches to manage chronic pain have led to some rather devastating unintended consequences. And as we'll hear in a few moments, the understanding of chronic pain as a disease now means that we recognize that it not only has physical and physiological causes or factors, but also other biological associations and risk factors, as well as, and increasingly importantly, recognize the social factors that go with the life of the patient who is experiencing chronic pain. If we look at the global burden of pain, it was important as I was preparing this session to look and see what do we actually know worldwide about the prevalence of chronic pain. Back pain has been fairly well studied, and there's quite a lot of data worldwide around the prevalence of back pain. But I found this study very interesting because I've long been convinced that as I walk around North American cities and countries and I see people using their cell phones, walking around on the metro, on the bus, on their bicycles sometimes, with their cell phones in their hand, I look at their heads flexed down. I think we're waiting for an epidemic of neck pain worldwide. And sure enough, it's clear that the chronic neck pain is a major, a high prevalence condition and something that perhaps we don't pay enough attention to. But the point here is to recognize that this is not just a local phenomenon of the developing nations. This is a problem that affects chronic neck pain as well as back pain, and other musculoskeletal pains affect us all. And it's a really important signal to recognize that we have to have a global response to this in the same way that we do for other globally important diseases. It's reached a point now where chronic pain actually has its own definition in the International Classification of Diseases. The ICD-11 recently published a list of pain diagnoses. And I invite you, I have some references at the end to get familiar with these, because as we study pain syndromes, if we can start to categorize them and label them correctly, we open the door to larger scale, well-designed epidemiological studies where we can now compare incidence of different pain syndromes in different regions and associated with different conditions. You can see here in many of these chronic pain disorders, there's a secondary nature to them. Chronic cancer-related pain obviously is caused by situations related to the tumor or the treatment of the cancer. And many patients who survive cancer diagnoses live with chronic pain as a result of either the treatment, the surgery, or the chemicals used to treat the pain or to treat the cancer. Post-surgical or post-traumatic pain can also give rise to chronic pain. Musculoskeletal pain like arthritis and other forms of chronic inflammatory disorders can give rise to chronic pain. Visceral pain from organs, from stomach, from peptic ulcers and so on can give rise to secondary pain as well. And we'll talk a little bit about neuropathic pain, which is caused by injury to the nervous system itself. What's remarkable about this list is the top one on the list, chronic primary pain. And this is now the condition with its own coding, which does not have an underlying cause. This appears to be present in the absence of any obvious tissue pathology or other diagnoses. And this covers things like fibromyalgia, interstitial cystitis, conditions which have been very poorly understood for a long time, where there's chronic ongoing pain, but the absence of any obvious organic pathology. And this now deserves its own criteria and its own diagnostic code in the ICD-11. So you can see chronic pain beginning to emerge now as a diagnosis in its own right. The other major influence, and we'll hear more about this over the course of the day, is the recognition that now the patient living with chronic pain is not just experiencing physical symptoms, but considerable impacts on their psychological and their social status, the so-called biopsychosocial model of pain, meaning that we have to now go beyond just the pure neurochemistry, neuroanatomy, and neurophysiology of pain and understand in much more relevant way, how does our social circumstance, how do our mood states affect the experience of pain? And can we use those as tools to address the experience of suffering with chronic pain? And you can see here from a recent Lancet editorial, a really good diagram of how the sociocultural, psychological, and biological factors combine to not only give rise to the experience of pain, but also the suffering that's associated with it. And for many people, the two things can be separated. I can live with pain but not suffer, or I can also have pain and experience tremendous emotional suffering, wondering why me, what is the cause, loss of identity, impact on mood and sleep. And of course, then this gives rise to a vicious circle of loss of function, changing pathways. We know the brain is very plastic. The system starts to evolve. There's a risk of use of or abuse of medications to try to treat the pain, as well as the ongoing and devastating psychological impacts, depression, anxiety, loss of sleep, loss of loss of cognitive function, but also then the consequent social implications, losing work, losing relationships with loved ones, withdrawal, and increased suicidality. So a very complex mixture now of different factors which give rise to the suffering of the person living with chronic pain. And of course, we can understand how this is possible now because we know that pain is not just a single unilateral experience, but a complex interplay of signals coming from the bottom up as well as from the top down. From the same editorial, and I invite you to read this if you want a primer on chronic pain and its pathophysiology. This is really the sort of the medical student takeaway slide, if you like. Because it gives rise to the three, or it gives light to the three major classifications of pain that we use now. And this is really something that I teach our fellows and students here at McGill, is when you're approaching a patient with chronic pain, the first thing you need to try to understand is what type of pain are you dealing with? The one that we most often focus on is nociceptive pain. This is perhaps because it's the one that we're more familiar with. But this is caused by some kind of nociceptive signal, and it's possible to have chronic pain that's been given rise from inflammatory or nociceptive causes like bone fractures, osteoarthritis, ulcers, kidney stones, and so on. These kinds of pain signals come from inflammatory or nociceptive signals, and this is relatively easy to treat. We use classic anti-inflammatories, steroids, and other analgesics. Where it gets more complicated, if you look on the top right, are the neuropathic pain conditions caused by nerve injury. And these can be central or peripheral. Peripheral in being things like diabetes or HIV, shingles, traumas to nerves. These damage to the nerves give rise to a very unique type of pain, which is associated with very different qualities, very different characteristics, and can become chronic and can become very, very difficult to treat and require a completely different arsenal of pain medications and approaches because the pathophysiology is so different. Moving from nociceptive and neuropathic pain then to nociplastic pain, this is a new diagnostic criteria. And this has been coined and has now been entering the pain literature in the last couple of years as a way to describe another cluster of pain syndromes which don't appear to have the same kind of obvious pathophysiological causes as do the neuropathic and nociceptive pains. And these are things like fibromyalgia, irritable bowel syndrome, certain types of chronic low back pain where the obvious pain generator cannot be identified. And here we have a very different pattern of pain pathophysiology. Now, the entire system of nociception, as I discussed at the very beginning, the peripheral sensitization, the central sensitization as the cortex and the brainstem reorganize in response to persistent pain inputs, as well as reductions in the descending control pathways, and increasingly recognize the importance of the inflammatory response, not just at the periphery, but in the spinal cord and in the brain, the activation of microglia, astrocytes, and others. And these cells are now beginning to experience a lot of interest as we start to understand how our inflammatory and neurological systems interact in the response to pain. Just as we start to wrap up, some very new data from my own clinic suggesting that as we look at chronic pain, one of the key questions is, how do we know who is at risk for developing chronic pain? Is there any way that as patients go through their acute pain, whether it's a surgical procedure or giving birth or having a biopsy, how do we know the kinds of patients that are at risk of developing this chronic pain syndrome? And is there a way that we can address that early and prevent the development? My colleagues have evolved a very recently published in Nature Medicine checklist for criteria. And it sort of reminds us of the importance of the biopsychosocial model, because what emerged from this very interesting paper was that there were 6 criteria that could robustly predict the development of chronic pain in people who suffer with acute pain. Do you have trouble falling asleep at night? Do you often feel fed up? Do you have low energy? Have you seen your doctor for depression, anxiety? Have you had any life stresses like a life injury or a life stressors like a serious injury, a serious illness, loss of a partner, financial stresses, and obesity, high BMI, over 30. These have all been now identified, and this kind of checklist will become hopefully used as a way to screen patients going through routine procedures to see if they might be at risk of chronic pain. So stay tuned to this space. I'm going to start to wrap up by pointing to the importance, as we talk through the study of pain, is recognizing how difficult it is to measure pain. Measuring pain, we typically do on a 0 to 10 scale. You'll hear plenty of discussions about pain scales from 0 with no pain to 10, the worst pain ever. Increasingly recognizing the importance of the quality of the pain, not just its intensity, but what type of pain. Is it burning or shooting or throbbing or tingling? These words have meaning for a patient, and when they use them to describe their pain, we need to be able to understand and interpret that. How unpleasant is the pain? I can live with a certain kind of pain, but at a certain point it becomes unpleasant. That separates the emotional from the physical aspects of pain. There have been a series of studies looking at defining what are the perfect criteria to use when you study pain, and they've evolved an impact criteria. And I invite you to check this website to see how pain measurement now is multifactorial. Pain measurement is not just intensity and quality, it's measuring quality of life, it's measuring emotional factors, it's measuring functionality, and only by addressing pain from multiple perspectives can we really understand what it is. There are no biomarkers, there's no tests that I can use to determine how severe or how real somebody's pain is. And fundamentally, And I heard mention of this at the beginning, but really where we need to go is, what is it of importance to the patient? What is it that this distresses you most, and how can we help address the aspect of pain that matters most to you? No shortage of controversies in the pain world globally. You don't have to have gone far to see the issues that arose with opioids as the opioid epidemic takes hold and continues to devastate lives here in North America. A great deal of the blame has been placed on overprescribing or the unrational prescribing of opioids for chronic pain. And in part because of an awareness of pain, the pharmaceutical industry took advantage of this, and we're still living with the consequences. This is really a complex issue, but I flag it because sometimes our best intentions to treat pain can also have some of the most devastating unintended consequences. You heard my interest in cannabis. It hasn't really evolved as a high evidence base for chronic pain management. It seems to be part of the toolbox in third line, but it's certainly a hot topic in North America and Europe, and continues to be a very hot political and economic question. The rise of nerve blocks and clinics here over 20 years, I've witnessed clinics open up with peripheral and central nerve blocks to treat pain with very limited evidence base. These are now being more tightly regulated. The rise of alternative therapies and the use of alternatives to manage chronic pain when all the conventional therapies haven't worked. But I would like to also just flag the lack of attention on trying to prevent and identify what it is that's giving rise to this in the first place. I think if we can start to crack that, we can start to actually help prevent the burden of chronic pain, as it's very hard to put the genie back in the bottle once chronic pain is already set in. Lastly, then, just a couple of thoughts about where we're going. There's tremendous work happening here at University of Toronto and across Canada, looking at the understanding of the importance of pediatric pain in predicting chronic pain. The experience of pain in childhood predisposes the brain, it primes the brain to understand pain differently, and therefore in adults, the experience of pain is heavily modified by the experience of pain in childhood. We're also learning that the microbiome, our gut contents, can also be modified, and we're seeing data from fibromyalgia where if you supplement gut microbiome from a patient with fibromyalgia with healthy gut microbiome, you can actually reverse and improve the experience of pain. And this is really, really exciting data that's emerging from us with collaboration from Israel. You can't go far without talking about psychedelics, and certainly in major mood disorders, this is becoming increasingly studied, but there's increasing attention because of this top-down effect of chronic pain. Is there a role for psychedelics in the management of pain? And lastly, my own personal project is the idea of looking at music as a therapy for pain. There's been plenty of preclinical evidence. We know a lot of people who use music to help them manage their pain. I think given that my nickname when I was at Irvine Hall at UE 25 plus years ago was John Lennon, it seems like an appropriate place for me to spend the last few years of my career exploring the possible role of music in the management of chronic pain. And finally, the importance of collaborating. So sessions like this, where we start to build bridges between institutions with interest in managing pain and its comorbidities, I welcome, and I'm very grateful for the opportunity to be with you. Sorry I can't be all together in person, but I look forward to ongoing challenges and ongoing collaborations. These are the references that I mentioned. The Lancet series is really good. The impact guidelines, the International Pain Society does not have a West Indian chapter, so I invite you to think about that. And the Power Over Pain patient resources, which are developed here in Quebec with collaboration with colleagues in Ottawa, really good tools to help patients understand how they can manage their pain. And I invite you to visit that site for resources. With that, I thank you very much again for your attention. And if there's time, I'm happy to take some questions and I'll monitor the chat. Thank you.
Thank you very much, Dr. Ware, for that very interesting opening presentation on pain, its pathophysiology, management, and global impact. As Bob Marley said, one good thing about music is when it hits you, you feel no pain. I don't know about no pain altogether, but it can definitely help. So I agree with you on that. Thank you for spending your Labor Day with us, and happy anniversary. I'm not seeing any questions in the chat at this time, but I do invite you, if you can, to just stick around and answer them as they pop up. At this time, though, I'm going to move on and invite our audience to listen to a young lady living with sickle cell disease share her experience with pain, followed by a word from two of our event sponsors, Arista Pharma and Indus. Thank you.
Good day, everyone. My name is Kimon. I'm 46 years old. I have SS disease, and I had a hemorrhagic stroke around 8 years ago, and I'm now on hydroxyurea. So I'm just going to share a little bit about what the sickle cell has been like growing up and my experiences to date. So growing up, I was very ashamed of my SS. In fact, I didn't want my close friends to know, because it meant that most of the things other kids were doing, example, swimming, dancing, racing, I couldn't do. So I didn't want to feel like I stuck out or like I was different. So I often hid and tried these activities, and of course I got sick, only to hobble to the nurse for my mom to pick me up. My parents were also very, very protective of me, so they didn't want me doing things like overnighting or staying at a friend's house. So I would say that my disease definitely prevented me from doing things, as I mentioned, earlier, that I wanted. Another thing that stuck out to me was that as I got older, I wanted to be a flight attendant, but the altitude affects sicklers, so I couldn't do that at all. Or I would want to go out and party and drink and, be cool, but that often would trigger an attack. So that was a way in which it limited me in growing up. In terms of the care that I received, well, I must say I'm very fortunate. As I explained, my family is very supportive, and I am able to afford private health care. I often visited the clinic, of course, in the days, but outside of those times, to the hospitals, on average, I was in there 5 to 6 times a year. Not lengthy stays, but just enough to get a drip and a painkiller, like short visits or overnight stays. What are my triggers? My triggers are cold, an infection, dehydration to a lesser extent, and high altitude. What does the pain feel like? Okay. It feels like a dull, throbbing pain, which increases in intensity to a sharp, sticking pain. I would also get bone pain after my attacks. So that's like a muscular pain that makes it difficult to stretch out a joint. So those are my triggers. When I'm very sick, I'm also very restless. I'm often rocking or moving just to try and find, a relief or a comfort from the pain. I would also often use heat or a rubbing to relieve my pain. The worst pain I've ever had was from an acute chest syndrome, that's in my mid-20s, which was precipitated by an infection and traveling. When the pain gets really, really bad, I cannot speak. It's difficult to speak because the effort to speak or even to move intensifies the throbbing, So I mentioned that I had a stroke around 8, 9 years ago, and the effects of that were that my mouth was twisted. I limped for a little bit. My short-term and long-term memory was short. It was difficult to recall things, and my speech was distorted. But thank God, and also for hydroxyurea, I really, that's an awesome drug. It really has made a difference in my quality of life, and I find that I'm more, how do I put it, I'm more sturdier, is that it? I'm more sturdier now, I can withstand more now. The things that used to trigger me before don't trigger me anymore. I'd have to be in extreme cold climate or in water for a long while before I would feel pain. So to anyone hesitant to try hydroxyurea, I would give it a shot. Of course, I know that there are limitations for women of childbearing age, but if that isn't a factor for you, go ahead and try it. It has been a remarkable drug, and it has really made a difference in the frequency and intensity of pain and the quality of my life overall. So thank you for the opportunity to share my SU experiences with you. And that's it. Bye.
Welcome to the world of Indus. And we are happy to join hands with you to serve the humanity across the globe through innovative healthcare brands. In just 16 years, Indus has grown from 1 to 120 products in 12 therapy areas. Today, Indus has spread its wings globally and is now present in 30 countries with 150 professionals spread across geographies like Asia, Southeast Asia, Africa, Europe, Caribbean, and South America. Excellence is not an act, but a habit at Indus. Our world-class products, affordable pricing, excellent supply chain, strong field force, and good business practices have accredited Indus with many excellence awards like Federation of Indian Export Organizations Export Excellence Award, Farm Excel Award, Brand of the Year Award in Ghana, and State Bank of India Financial Discipline Award. What's more, now Indus brings you a 5-minute miracle. In today's fast and modern lifestyle, the incidence of heartburn due to acid reflux and GERD is alarming due to stress and busy schedules, overeating, eating irregularly or too quickly, eating just before bedtime, fatty, spicy and fried junk foods, caffeinated drinks, carbonated soft drinks, acidic juices and alcohol, and smoking. As published in many international journals, hyperacidity, acid reflux and GERD lead to heartburn. In hyperacidity, the excess acid from the stomach can move upward into the esophagus, known as acid reflux. As the lower esophageal sphincter, which joins the esophagus and stomach, becomes weak. Since the esophagus is not well protected like the stomach, the acid can irritate the lining and cause inflammation in the esophagus. This causes painful symptoms that can last for a few minutes to hours and can occur more frequently within a week. This chronic form of acid reflux is known as GERD, that is, gastroesophageal reflux disease. The major symptoms of heartburn due to acid reflux and GERD are a burning feeling in the chest, epigastric pain, a bitter or sour taste in the mouth, nausea after eating, regurgitation, frequent burping, flatulence and gas, stomach discomfort, difficulty in swallowing, sore throat and dry cough. The question now is, do regular antacids help? In hyperacidity and GERD, regular antacids can only neutralize the acids, leaving acid reflux unattended. To treat hyperacidity, acid reflux and GERD, Indus Life Sciences comes with a unique third-generation antacid named NewGel, which controls acidity, prevents reflux. NewGel offers balanced combination of alginic acid, magnesium hydroxide, dried aluminum hydroxide, magnesium trisilicate, and dimethyl. When a person takes NewGel, the raft-forming alginate physically blocks reflux through a unique mechanism. When alginic acid comes in contact with the gastric acid, the raft-forming alginate, which includes natural algae, begins to form a light but strong foam barrier known as raft. This raft floats on top of the stomach contents and prevents acid from moving upward to the esophagus. The alginate raft formula, containing balanced antacid components, offers a speedy onset of action in less than 5 minutes and provides rapid relief from acid reflux with effective neutralization of stomach acid. New gel has long-lasting effects up to 4 hours, since the raft can be retained in the stomach for several hours. Dimeticone in new gel is an anti-foaming agent. It reduces the surface tension of gas bubbles, causing them to combine into larger bubbles in the stomach, which can then be passed more easily by means of belching. Dimeticone thus relieves flatulence. New gel is recommended in hyperacidity, GERD, gastroesophageal reflux disease, gastritis, flatulence, and as an adjuvant to NSAIDs. New gel is available as New Gel 200 ml suspension and New Gel tablets with delicious mint flavor. New gel is safe in pregnancy. New gel is sugar-free, hence safe for diabetics. For patients with symptomatic pain due to gastric and duodenal ulcer, Indus also presents New Gel O, the alginate raft-forming antacid with mucosal anesthetic agent oxytocin. Oxytocin is a potent, safe, local anesthetic agent that provides prolonged anesthesia of mucous membranes, thereby offering prompt and prolonged relief of pain. New Gel O is available in 200 ml suspension with mint flavor. New Gel and New Gel O. Raft formation reduces intensity and frequency of reflux attacks. Works in less than 5 minutes. Offers long-lasting effect up to 4 hours. Sugar-free, hence safe for diabetics. Delicious mint flavor improves patient compliance. We thank the entire medical fraternity for supporting Indus in our journey towards better healthcare.
AminoPep Fort in PDF. The WHO and UNICEF report highlights good nutrition allows children to survive, grow, develop, learn, play, participate, and contribute. Nutrition, including protein in the form of amino acids, play an important role for both physical and cognitive health. Undernutrition in children can lead to weight loss and low immunity. This in turn leads to increased susceptibility to infections, which results in loss of appetite, loss of nutrients, malabsorption, causing undernutrition. Hence, the vicious cycle of undernutrition in children can prolong school absence, hampering their academic performance. As per eBiomedicine, stunted growth in children coincided with lower serum concentrations of all essential amino acids like tryptophan, isoleucine, leucine, valine, methionine, threonine, histidine, phenylalanine, arginine, and lysine compared to non-stunted children. Amino acids in therapy highlights growth, development, and function depend on the correct supply of amino acids. To build a strong immunity and growth in children, Indus Life Sciences presents AminoPep Fort. AminoPep Fort is a 10-on-10 combination of 10 essential amino acids fortified with multivitamin and zinc in a delicious syrup. The 10 essential amino acids meet the increased demand during infections. Reputed journals like Genes and Nutrition 2017 highlights that essential amino acid supplementation enhances muscle protein synthesis, physical endurance, and increases immune function. The British Journal of Nutrition highlights vitamins and trace elements like zinc also assist in protective activities on immune cells and are essential for antibody production. Nutritional benefits depend on the quality of protein, which is assessed by essential amino acids, composition, digestibility, and bioavailability of amino acids. The protein efficiency ratio, biological value, and net protein utilization depends on essential amino acids content. AminoPep Fort offers free form of all the essential amino acids, which are immediately absorbed into the.
Good day, everyone. Today, the team at Arista Pharma would like to highlight a few of our products that represent our commitment to quality and innovation. We are endeavoring to ensure that your patients benefit from products that meet their needs. Because at Arista Pharma, quality is the unit we count. With modern technologies, we are able to quickly connect and access critical information in the blink of an eye. These capabilities are made possible through the use of apps. And we all know that by utilizing these apps we can be rewarded with convenience. They may also allow us to create and maintain long-lasting connections. And sometimes, they just provide valuable relief through entertainment. But today, we want to bring your focus and attention to a few different types of apps. Simply put, we want you to pay attention to our Arista Pharma products. Now let's enter our App Store. Our first app that we will be focusing on today is our Flutica. Flutica is our fluticasone furet at 27.5 micrograms per spray. Some of the benefits of Flutica include a gentle mist, no drainage, no aftertaste, and low bioavailability. Next on our list is our Arrow Flows. A few features of our Arrow Flows include the affordable prices, the long history of treating asthma symptoms, its ability to reduce the exacerbation of COPD, and its bronchodilator and anti-inflammatory properties. Now, in keeping with our apps for asthma, we would also like to highlight our Soul Flow. Soul Flow is our salbutamol at 100 micrograms per puff, offering 200 puffs in a wonderful CFC-free formulation. Soul Flow has a rapid onset of action and acts within 5 minutes. The relief from Soul Flow lasts up to 4 to 6 hours and costs less than $300 after the NHF subsidy is applied. And for your patients who may suffer from dry eyes, we also have an app for that. Introducing Cystair. Cystair is our unique combination of polyethylene glycol and propylene glycol. Now with Cystair, both polymers combine to create a unique formulation that offers 6 times the lubricity of most other drops on the market. So we are encouraging you and your patients to feel the hydration. So now, it's time for a practical demonstration of our apps. Let's say you are visited by a patient who has been plagued with seasonal allergies. Now they are showing signs of shortness of breath, indicating a likely asthma attack. This patient can certainly benefit from a few of our apps. To start, you can place the patient on Flutica at 2 sprays in each nostril once daily for up to 14 days. Secondly, you can add our rescue inhaler Soul Flow at 2 puffs every 4 hours. Finally, for maintenance, you can add our Arrow Flow at 2 puffs twice daily to ensure that the patient gets lasting relief. Now all you need to do is to just add your signature and send your patient on their way to access their new apps at the nearest pharmacy. Now as we close, we would like you to keep our Flutica, Arrow Flow, and Cystair in mind, and we hope you enjoy the rest of the conference. Thank you.
Okay. Having previously heard Dr. Ware's presentation on general pain and Ms. Thomas's personal experience with pain, we now turn to Dr. Leslie King to speak more directly to pain in sickle cell disease. Dr. Leslie King is a pediatrician and head of clinical services at the Caribbean Institute for Health Research, with 20 plus years of experience in clinical care for persons living with sickle cell disease. She received her MBBS from the University of the West Indies in 1992. She later trained at the Royal Hospital for Sick Children at York Hill, Glasgow, and its neighboring hospitals, and was awarded the MRCP in 1997. She returned to Jamaica in 2000 to work as a pediatrician at the Sickle Cell Unit, then under TMRI. Her research areas are focused on aspects of clinical care, including newborn screening and hydroxyurea use in sickle cell disease. She's a member of the Sickle Cell Technical Working Group commissioned by the Ministry of Health and Wellness of Jamaica in 2012 to implement island-wide newborn screening, and now focused on improving access and standard of care for persons living with sickle cell disease. She has co-authored papers on newborn screening, hydroxyurea, renal and vasculopathy disorders in sickle cell disease. Thank you for joining us today, Dr. King.
Thanks, Dr. Chin. Morning, everybody, and thank you all for joining us here at this pain symposium. As Professor Nani said, it's Sunday. We know a lot of us like our Sundays, but thank you all for being a part here. Mark, happy anniversary. We've known each other for some time now. Your partner was with us throughout med school also, so happy anniversary to both of you. And thank you for setting the stage for me for my upcoming talk. Now let me start sharing my screen and let's see if we can get this going. All right, Sam, is everything good there?
Everything's good.
Okay, great. Okay, so this morning I'm tasked with helping us to better understand sickle cell disease, pain. I'm going to start with a brief overview of sickle cell disease, basically to set the stage for a number of the discussions and conversations that are going to follow me. The pathophysiology of pain in general was ably covered by Dr. Ware, and so I'll be able to just kind of glide over this. And then we will go into the meat of the matter, sickle cell disease pain. And then I'm also going to share some of the recent work that we have been doing at the Sickle Cell Unit with regards to pain. So sickle cell disease is a chronic multisystem, potentially debilitating disease, which is characterized by severe, unpredictable pain crises, chronic organ damage, and reduced life expectancy. It is the most common monogenetic red blood cell disorder worldwide, and it results from the inheritance of the abnormal sickle gene. This leads to the production of an abnormal hemoglobin, your sickle hemoglobin, and sickle hemoglobin within your red cell, under certain conditions, tends to form polymers or these long chains, which distort or change the characteristics of the red blood cell. And so what you end up with is an abnormal red blood cell that is sickle-shaped, it is sticky, very rigid, and has a very short lifespan. Sickle cell disease is actually an umbrella term, and under this umbrella, you have a number of different forms or genotypes. It is autosomal recessive inheritance, with the most common genotype being your homozygous sickle cell disease or your HBSS disease, which results when you inherit a sickle gene from both parents. Sickle cell disease also occurs in the heterozygote state when you inherit the gene for sickle hemoglobin, along with the gene for another abnormal hemoglobin disorder, such as hemoglobin C or sickle thalassemia. Those are the two most common heterozygote forms that we certainly see locally. But there are other forms that we see, SO Arab, SD Punjab, S Lepore, and so it's very important that we are all aware of these forms. Now, I like this slide because it basically helps to put sickle cell disease in context, with global figures. Now, we know that Africa has the highest incidence of affected births per 1,000 live births annually, okay? But what this slide highlights is that the Caribbean has the second highest incidence of birth worldwide. Now, what that means is that if you practice in the Caribbean, you are very likely to encounter a patient with sickle cell disease. And as such, it is going to be very important that we all understand the basics of sickle cell disease and how to manage our patients effectively. Sickle cell disease is a common genetic disease in Jamaica. 10% of our population have the sickle cell trait. Another 5% have other significant traits, such as the C and the thalassemia trait, which puts them at risk of having a child with disease. 1 in every 150 live births in Jamaica will have a form of disease. So currently, based off of our birth rate, we will have anywhere from about 200 to 250 babies born annually in Jamaica. This may seem like a small number, but for our population, it is actually quite significant. And we estimate that there are around 19,000 persons living with disease in Jamaica. The risk of death is highest in the first 3 years, and common causes of death and morbidity include infection and acute splenic sequestration, and we consider these preventable deaths with simple interventions. The good news with sickle cell disease is that because of improved care from all the lessons that we have learned, we now have increased survival of our patients. And the average lifespan in Jamaica for a patient with homozygous HBSS disease is now 42 years, but that's just the average. So clearly we have some who died before and some who, are much, much older. In the picture here, you will see our oldest patient when he came to the sickle cell unit for his 90th birthday, and this was pre-COVID. So he's still alive. He actually has SC, and he's now probably about 94, 95 years old. All right. So, and we do have, I think our oldest SS patient is maybe about 88 years old. So you can see that there is quite a wide age span. However, with increased survival, we do see emergence of associated disease such as renal disease. And this highlights the importance of, routine health maintenance, which allows for opportunities to detect, these emerging diseases, treat, and try to delay complications. Sickle cell is a very variable disease, one of the reasons why it's interesting and challenging. So there is variability to be between genotypes. So we tend to talk about our severe genotypes, or SS and sickle beta naught thalassemia major, and our mild genotypes, SC, sickle beta plus thalassemia. But within genotypes also, there's also a lot of variability. So SS is typically a severe disease, but it also could be a very benign disease, which an incidental finding later on in life. Complications of sickle cell disease are many. Anywhere that blood travels can be impacted by sickle cell disease. Complications may be acute, and they may be chronic. Pain has been mentioned before, and the reason that we're all here today is the hallmark of sickle cell disease. Many of our complications are associated with pain, and the most common complication is our acute vaso-occlusive painful crisis. Now, here's where I'm going to be able to slide over a little bit quickly, because Mark, thankfully, has taken us through the anatomy and physiology of pain quite in a very clear and concise manner. So pain is an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage, or described in terms of such pain. And that's a different definition from the International Association for the Study of Pain. As Mark mentioned, the pain, how we perceive pain is complex. It involves both an ascending pathway, but also a descending inhibitory pathway. And this modulates the pain signal and subsequently how we perceive and respond to pain. When we don't control our acute pain properly, what happens over time is that you get repeated stimulation of the neurons. And as a result of that, that leads to both peripheral and central sensitization. And it causes alteration of your pain sensation, and it lowers the threshold for pain. Over time, again, with this peripheral, with the sensitization of our peripheral and central nervous system, you get remodeling of your neurons, you get neuroplasticity, which is basically the reorganization of your synaptic connections, and you have the development of chronic pain. The pain experience is highly variable between individuals. A direct correlation between the activation of nociceptors and the sensory experience of pain is not always apparent. Emotional state, degree of anxiety, attention and distraction, past experiences, memories, and many other factors can either enhance or diminish the pain experience. And as we said, there's evidence for a top-down modulatory circuits that profoundly change the sensory experience of pain. Now, sickle cell disease pain initially was thought to be, just acute pain, and which occurred from these repeated vaso-occlusive crises. We now know that sickle cell disease pain is a lot more complex than that, and it involves not only acute pain, but chronic pain. Acute pain may be acute non-crisis pain. Again, typically, or most commonly, you have your acute vaso-occlusive crisis, but there's also acute exacerbation of chronic pain. Chronic pain may be related to an identifiable cause, so there's some associated pathology, and we'll go into this a little bit more. But again, more and more, we're having chronic pain that there is no identifiable cause. And contributory factors to this would include chronic nociceptive pain, chronic inflammatory pain, and more, the recognition of neuropathic pain, which is resulting from sensitization of our peripheral and central nervous systems. Sickle cell disease pain can start as early as 3 to 6 months, and we know that dactylitis is often the very first presenting complaint, and that starts anywhere from 4 to 6 months, okay? Over 95% of persons with sickle cell anemia will experience recurrent severe pain within their lifetime. And over 90% of the pain crises that persons with sickle cell disease have are actually managed at home. So what we see in our practices in emergency is really just the tip of the iceberg. There is an increasing burden with age. Recurrent acute vaso-occlusive crises is the most common cause of morbidity and hospitalization, and severe pain is the single most important predictor for early death. Patients that have been labeled difficult patient or addicts based on the suspicion of drug-seeking behavior, overuse of healthcare facilities, dependence on opioid analgesics, and confrontational behavior to healthcare professionals, we all see. But in fact, what studies and reports have shown us is that opioid addiction is really rare in sickle cell disease. In the US and the UK, it's estimated that 10 to 15% of adult patients are labeled as difficult patients. When we look on our population in Jamaica, less than 1%, and 60% of them actually have 2 or more documented chronic painful conditions. And again, studies have shown that the mortality rates among difficult patients is 3 times higher than the rest of the sickle cell population. So this population of patients, your so-called difficult patients, is actually a very sick population. When we look on the causes of acute pain, they may be directly related to sickle cell disease. So, many of our acute complications, again, acute painful crisis being the most common, but they may also be not directly arising from sickle cell disease. So you have, like peptic ulcer disease from high NSAID usage. withdrawal from opioids, and so forth. When we look on the pathophysiology of acute pain, it's basically related to vasocclusion, which is leading to hypoxia, ischemia, and eventually tissue damage. The inflammatory mediators that are released from the injured cells, macrophages, mast cells, and platelets, will activate the nociceptors on the peripheral afferent, thus initiating the nociceptive insult. So this initial acute pain is nociceptive in pathology. And it is a combination of hypoxia, reperfusion injury, ischemic tissue damage, and inflammation that makes the pain of sickle cell disease unique. The acute pain for vaso-occlusive often arises just a sudden onset of severe pain. It's very unpredictable. It may be triggered by known or unknown risk factors, and our patient already, alluded to some of these, and is often described as continuous throbbing in nature. As mentioned, it causes significant morbidity. 90% of sickle cell-related admissions are due to acute painful vaso-occlusive crises. It is frequent and severe. So the Pisces study, which is a pain in sickle cell epidemiology study, found that patient-reported crises on 16.2% of days with a mean intensity of 5 and 5.9 with and without utilization. And that speaks to them seeking out, medical care. The multicenter study of hydroxyurea found 44% of patients had 3 to 5 annual crises. And we know that acute painful VOCs may lead to other complications such as acute chest syndrome, multi-organ failure, and sudden death. Common triggers include infections, changes in temperature, stress, emotional, physiological. We know that for many of our women, menstruation is a trigger, and also dehydration. The pain cycle has been studied, and it is described as evolving through 4 phases: a prodromal phase, initial phase, an established phase, and a resolving phase. Pain tends to be most severe around day 3. It kind of then plateaus, and then usually or maybe around day 7, you start to see resolution. In this, studying the pain crisis, the pain cycle, a number of objective measures, clinical signs and symptoms have been described compared to the baseline. So in the established phase, you will see increased temperature, increased white cell count, lowering of their hemoglobin. And in the resolution phase, what you will see is increased fibrinogen, increased platelets, increased plasma viscosity. And this is what is thought to contribute to a hypercoagulable state in this resolving phase, and what predisposes our patients to recurrent attacks when it is assumed or when it is felt that the acute painful crisis has resolved fully. And again, this is evidence when we look on readmissions after readmissions for acute painful crisis, with studies reporting anywhere from about 38 to 50% readmission after an acute episode within 1 month, and anywhere from 16 to 22% within 1 week after discharge. With recurrent painful crises, 2 models. So what could be happening is, 1, you have 2 distinct episodes and with a pain-free episodes in between. Or what happening as patients age is that there's now baseline pain, and the intensity of this baseline pain between 2 acute episodes will vary. The acute painful crisis is said to run a course of up to 10 to 14 days, including the prodrome phase. Pain-free periods lessen with increasing age. Approximately 50% of adults will have persistent mild to moderate pain between acute pain crises. Risk factors for frequent acute vaso-occlusive crises include older age, higher hemoglobin or hematocrit, and lower fetal hemoglobin. And acute pain episodes are associated with inflammation that worsens with recurrent episodes. One of the reasons, again, why over time, your severity of your acute episodes tends to increase. Chronic pain is pain that persists or recurs for 3 months or more. And it's often described as deep, nagging, and achy. As mentioned, it may or may not be associated with pathology. And for patients who have chronic pain, it's important that we rule out other pain syndromes such as collagen vascular disease, rheumatoid arthritis. The multicenter study of hydroxyurea reported that 44% of patients had daily chronic pain with a mean intensity of 4 or more. And the Pisces study found pain on 55% of days with mean of 4.5. Pain that is related to pathology, common pathology includes avascular necrosis of the femoral and humeral heads, leg ulcers, arthropathy, vertebral body degeneration or collapse, or it may be pain associated but not necessarily directly arising from sickle cell disease. Osteomyelitis, constipation, we know occurs in a number of our patients with acute opioid usage. For pain without pathology, this is the intractable pain experienced in between acute vaso-occlusive crises. There's no correlation with known markers of disease, and it is associated with a high somatic burden. Recurrent attacks of acute severe painful crises, especially if not adequately treated, will lead to the chronic pain syndrome, and these repeated nociceptive inputs from the vaso-occlusive crises lead to functional and structural changes in your nervous system, altered processing, and neuroplasticity. Neuroplasticity speaks to the rewiring of our brain. So we now have lowering of a threshold for pain, and we now have our patient will now experience allodynia, which is basically innocuous stimuli becoming very painful, such as light touch, or hyperalgesia, where they will now have an exaggerated response to normally mild painful stimuli. There's also expansive receptive fields, so there's hyperalgesia beyond the area of original injury. There is also hypersensitivity and hyperexcitability in the spinal cord, the so-called wind-up phenomena, whereby repetitive severe painful stimuli will lead to progressively increasing number of pain impulses being transmitted. And here is where we now move on to this neuropathic pain, which is becoming of so much more interest generally speaking, in chronic pain, and certainly in our patients with sickle cell disease. The International Association for the Study of Pain defines neuropathic pain as pain that is caused by a lesion or disease or dysfunction of the somatosensory system. It's often described as numb, tingling, lacinating, shooting, spontaneous or paroxysmal in nature, and is associated with a sensation of pains, pins and needles, hyperalgesia, and allodynia. It's severely enhanced by cold or heat exposure, and it is likely due to injury or dysfunction of nerves in the peripheral and central nervous system. Part of the problem is that we don't routinely assess or manage neuropathic pain in our clinical practice. And this is important to highlight because our usual pain management strategies will not address neuropathic pain effectively. Very few studies have been done with sickle cell disease and neuropathic pain. In one by Bradbo in 2015, they found a prevalence of 30 to 40% of neuropathic pain in their population, increase in prevalence with age, higher in females, and only 5% of persons with neuropathic pain were actually on specific treatment. This is a hypothetical model of pain, which I found and which I like, because it basically is trying to highlight to us when we should consider evaluating for neuropathic pain. So yellow represents a chronic baseline pain, and you can see that not much in childhood, but certainly with adolescence and young adulthood, young adults, you start to see your chronic baseline pain increasing. The red represents the severity of acute painful crises, and as with age, there is increased severity of our painful crises. The blue represents the required opioid dose to achieve analgesia, and as you will see, this will become harder as chronic pain and neuropathic pain develop over time. And so the suggestion and the recommendation here is that we should consider evaluating for neuropathic pain when our baseline pain starts to increase significantly, or when it is that opioids or management or analgesia, opioids, it seems to be refractory to pain. So our pain is not responding to opioid therapy. So that's just a model with, to help. But how do we assess neuropathic pain? And here's where the challenge occurs, because there's actually no objective measure. And we have to rely a lot on our subtle cues from our patients in the history and physical examination. And so as clinicians, we have to really be intent in trying to elicit these cues from our patients. For patients, it may be hard because the gradual transition in the phenotype from nociceptive to neuropathic or mixed type pain is harder to recognize. And so, as I said, we have to be intentional in our history and physical examination with our patients. There are a number of methods that have been described or are used then in assessing neuropathic pain. So there is your patient-reported outcomes, which is your gold standard at the moment. The ones that have been used in sickle cell disease include your Leeds assessment of neuropathic symptoms and signs, the pain detect, the pain report, okay? But none of these have actually been validated in sickle cell disease, but we still kind of use them. Then there is the quantitative sensory testing, which is where we're using a digital instrument to help us to determine or detect neuropathic pain. Instrument is, however, expensive. It's very time sensitive, this method of testing. And really and truthfully, it's really only used in research studies at this time. And then there's also the recommendation of imaging studies. But again, how helpful? If we look on some of the studies coming out of the sickle cell unit, this one by Ramsey et al. Exploring acute, chronic, and neuropathic pain. This was a cross-sectional study looking on patients aged 14 years and older. 257 participants, 55.6% were females, 75% hemoglobin SS, a mean age of 31.7 years. And they found a prevalence of chronic pain and neuropathic pain in 21.5% and 17.9% of the study participants. Female sex, the presence of current leg ulcers, and the use of a strong opioid in the last 4 weeks produced higher odds of neuropathic pain. And older age, milder genotypes, and daily analgesic use had the highest odds of chronic pain. When you look on the sensations associated with chronic pain, all of these were significant, and these include burning, tingling or prickling, pain on light touching, sudden pain attacks like electric shocks, numbness, cold or heat being occasionally painful, and slight pressure triggering pain. In another study by Bartlett et al., looking on health-related quality of life and neuropathic pain, 236 participants, 56.8% were female, mean age 33.2 years, 75% SS disease, and neuropathic pain here was present in 26.7% of these participants. And it was found that neuropathic pain significantly reduced emotional and social functioning and also worsened sleep and stiffness. Now, these studies and a number of the other studies have highlighted a gender difference with regards to pain, with women seemingly being worse off. And this is what has led to our current study that is being undertaken at the Sickle Cell Unit, or so-called Women Study, which aims to determine the association of levels of sex hormones with the severity and frequency of acute vaso-occlusive pain, and the presence of both neuropathic and chronic pain among women with sickle cell disease. Also to determine the association of levels of sex hormones with thermal and pressure pain thresholds measured by QST. And lastly, to also determine the changes in thermal and pressure pain during the follicular and luteal phases of the menstrual cycle along women with sickle cell disease. And as I've mentioned before, menstruation does seem to be a trigger for painful crises in many of our female patients. If you want to hear more, I'm just going to highlight, there is a webinar that you can sign up for, Influence of Sex Hormones and Menses on Sickle Cell Pain in Women. That's on September the 12th. Okay, so you can always Google that and find that. In summary, for many sickle cell disease patients, pain is a rule rather than the exception, and it is likely multifactorial in etiology, not simply vaso-occlusive. Pain prevalence is probably vastly underestimated by healthcare providers, resulting in misclassification, distorted communication, undertreatment, possible unnecessary loss of employment and productivity by patients and caregivers, and mistrust even from family members and friends of patients. All pain is not acute. A large component is chronic. Neuropathic pain is poorly understood, it's under-recognized, and it is clinically undertreated. And as clinicians, researchers, employers, policymakers, etc., we all really need to understand better, sickle cell disease pain, so that we can continue to improve management strategies and, improve the quality of life of our patients who do have a significant burden because of their disease. Thank you all very much and enjoy the rest of the conference.
Thank you so very much, Dr. King, for a great talk introducing us to sickle cell disease pain. I can now leave the floor open for 5 minutes for questions and answers. Let's see. Does anyone have any questions for Dr. King?
So I see one here. Thank you for your excellent overview. I have 2 questions. Has there been any impact on genetic counseling on the current incidence of SCD when compared to 3 to 4 decades ago?
Essentially, no. Neil Hanchett had done a study looking on the prevalence of the sickle cell gene, and really and truthfully, certainly in our population, we have really seen no difference. And when we look on our newborn screening babies, we're still seeing the same incidence or prevalence as in past years.
Thank you so much. Second part of the question, we still see a number of patients with recurrent complications, even patients on hydroxyurea. Are there avenues or plans to explore stem cell transplants locally?
I'm not aware of any plans at the moment, and maybe that is something that would be better discussed with our hematologist colleagues. There is a lot of support that is required for transplantation, and I do not know if currently our environment, we have the resources that would allow us to do transplantation.
Thank you so much. How does pregnancy affect sickle cell pain?
Well, studies have shown again that the third trimester is, again, another high-risk period for sickle cell disease pain.
Thank you. Interesting question here. Not sure if you have any data to support or see where there's a study to see if there are any chronically opioid dependent patients in Jamaica.
I'm not aware that we have any studies to say that we have. Prof. Knight Madden, are you there? If we have any opioid dependent patients. I'm not aware of any studies. And as I said, a lot of the patients who we think are opioid dependent or drug seeking in their behavior are actually trying to relieve their pain. All right. And
Right.
a lot of them have pathology. A lot of them, they are a high-risk group for mortality. And so we really have to look on this group of patients with, a different mindset and kind of move away from us just thinking that they are opioid dependent, because they really do have problems.
Thank you so much. What can be done for patients who turn up to the emergency room requesting only pethidine or analgesia?
Okay, so we're going into some of the, and hopefully, our next talk will actually address some of this. But this is some of the challenging areas, all right, with management of sickle cell disease, and there's no one answer. So pethidine was the kind of first opioid that was used for sickle cell disease pain management. And so a number of patients, are used to pethidine, and that is what they find works for them. But over time, what we have realized is that certainly, morphine is a much better opioid in managing pain. And so a lot of times we have to find out from our patients. So there needs to be a discussion with our patients. Why is it that they are requesting pethidine? Okay. Is there a problem with morphine? Because there are some patients who truly have an allergy to morphine, and so may require pethidine. We also have to, try to educate our patients on the benefits of morphine and the risk factors of using pethidine, especially prolonged, usage of pethidine, and that we can actually get better control of their pain with morphine, generally, than with pethidine.
All right, thank you so much. So our last question for this section, and I'll invite Dr. Ware, if he's still on, to assist where possible. If we find out a patient is high risk, are there any mitigating strategies we can use to reduce the risk of developing chronic transformation of acute pain or trauma?
Can you repeat the question, please? I only caught
definitely.
the tail end of it.
No problem. If we find out a patient is high risk, are there any mitigating strategies we can use to reduce the risk of developing chronic transformation of acute pain?
It's a great question. We're only beginning to identify what those risk factors might be, although we've known and we've sensed for a long time that things like socioeconomic status, there are biological factors that we've mentioned, gender, as Leslie mentioned, and sex is an important characteristic. But to what extent you can modify those risk factors, and then by modifying them early, change the likelihood of development of chronic pain is extremely early. So I don't know that we know this yet, other than the straightforward common sense approach, which is working on the sort of biopsychosocial model, improved relaxation, improving sleep, weight loss, increased activity. These basic lifestyle recommendations are probably the best recommendation we can make to prevent chronicity.
Thank you so much. So, thank you, Dr. Ware. Thank you, Dr. King. Back to you, Dr. Chin.
Thank you very much. So thank you for providing us with a better understanding of sickle cell disease pain, Dr. King. Now, how do we manage it? From med school days, we knew that management can be broken down into pharmacological and non-pharmacological management. So to take us through the pharmacological management of sickle cell disease pain, I invite Dr. Patrice Simmons-Brooks to our virtual podium. Dr. Simmons-Brooks is a physician with over 12 years of clinical experience. She is a proud past student of the Holy Childhood High School, where she graduated in 2001. She then went on to pursue a Bachelor of Science degree in biochemistry and then an MBBS at the University of the West Indies, Mona, in 2004 and 2011, respectively. She has completed a master's in international public health at the University of Liverpool, John Moores, in the UK earlier this year. She has been a medical officer at the Sickle Cell Unit at the University of the West Indies, Mona campus for the past 9 years. Her research interests include women's health, sickle cell advocacy in the workplace, and geriatric assessment of the sickle cell disease patient. Thank you, Dr. Simmons-Brooks.
Okay, thank you, Nikki, for that introduction. Thank you for having me. It's always a pleasure to share with my colleagues, and especially on a day that, where most of us can, be in the comfort of our home and learn more about sickle cell disease. Today, I was asked to present on the pharmacological pain management in sickle cell disease. Thanks to Dr. Weir and Dr. King, my presentation can move along very quickly as it relates to the pathophysiology of pain. We'll be discussing the traditional analgesics that we use to manage sickle cell pain. We'll be looking at some of our disease-modifying drugs like hydroxyurea, and we'll also be looking at emerging treatments. Not sure what is going on. Not sure what is. I'm having some technical difficulties. Bear with me.
That's fine. We're seeing your screen. We're now on the slide that says chronic multi-system disease.
Okay. All right. Sorry about that. I'm gonna have to go back a few slides. Okay, sorry about that.
That's totally fine.
So sickle cell disease, as was discussed, is a chronic multi-system disease that is characterized by severe and unpredictable pain crisis. You can have chronic organ damage, and persons are at risk for increased morbidity and mortality. The interesting thing about sickle cell is that almost every symptom bears pain. And we at the Sickle Cell Unit always remind our colleagues when we get an opportunity like this is that it must be remembered that pain is the insignia of sickle cell disease. And we must recognize that if we are to effectively treat sickle cell disease, we must put pain at the treatment of pain as at the forefront. We have several causes of pain. As Dr. King discussed, pain can be acute, chronic, or neuropathic. But we must also remember that not because a sickle cell patient presents in pain means that they're having a crisis or something related to their sickle cell. Sickle cell patients can experience other types of pain, and usually they can distinguish their sickle cell pain as opposed to the other cause of pain. If a sickle cell pain person presents with chest pain, we should not, especially if the person has other comorbidities, and if the person is an adult, we need to explore causes like an acute myocardial infarction. If a sickle cell patient has recurrent joint pain and swelling, we need to look at other causes such as collagen vascular diseases, such as lupus or rheumatoid arthritis. If we notice that we have our female patients coming with pelvic pain and it's cyclical, we need to explore other causes like menstrual pain, endometriosis, adenomyosis, endometriosis, and adenomyosis. If sickle cell patients report chronic pain and they have constitutional symptoms like fever and weight loss, we need to explore cancer. So these things used to be, because sickle cell was generally a disease of childhood, we didn't get to this point where there is now a new era where sickle cell patients are experiencing some of the chronic illnesses seen in adults. And we must, in any management of pain, look at the patient as a whole and not just as a sickler. Now, this CDC had a conference recently, and they were talking about just pain in general, and they were saying that Dr. Christopher Jones said that patients with pain should receive compassionate, safe, and effective pain care. We want clinicians and patients to have the information that they need to weigh the benefits of the different approaches to pain care with the goals of helping people to reduce their pain and improve their quality of life. And I put this in red because this is something that I really feel strongly about. As doctors, we are not only just looking at treating the patient's symptoms, but we also need to remember that we need to provide them, empower them with the information that they need, and also empower them to improve their quality of life. So they must have some autonomy. It's not that here you present with pain, here are the medication that I am offering you. There should be a discussion. We should aim to educate our patients, and we should come to some consensus with the patient. So just a reminder of previous slides that, the pathophysiology of sickle cell, elucidating that by research and, seeing the natural history of sickle cell play out, it has empowered us to develop targeted strategies, not only just looking at pain as in the sickling, but also looking at other biological factors and other biomarkers that can aid in the management of pain. We now know that, that there are interactions of the red blood cells, the reticulocytes, the neutrophils, the platelets. It's not only just about sickle cell being a red cell disease. You have cellular adhesion, biomarkers at play, we have inflammatory mediators, we have oxidative injury, increasing vascular tone, vasospasm, and also, as we knew before, there's polymerization. So taking all of this into consideration, we now know that we can employ other medications to treat sickle cell. Now, I am a sports fanatic, and this is knowing this, getting this information that there are other things at play. It is an opportunity for us to grow as physicians. So with this new information, we can marry the old information with the new to come together with a winning formula to assist our patients in managing their illness. As was discussed before, they said we acknowledge that pain can start as early as 3 to 6 months. And as you get older, yes, you have chronic pain, acute pain in their childhood, but as sickle cell patients get older, they can experience both acute pain and chronic pain. But what we know about patients that have frequent pain is that it is the single most predictor of early death. So if it is that we are about empowering our patients, we are empowering them to live longer, and we are empowering them with information for them to improve their quality of life. We must remember that many times persons that are labeled as addicts, and I hear the questions coming in are already about, patients coming in and asking for pethidine. People ask for things that work. And even if they're addicted to pethidine, my stance is that we are the ones that introduce it to them in the first place. So therefore, we bear a responsibility to treat this addiction or to diagnose what the patient is experiencing, if it is true addiction or it is pseudo addiction or poor management of chronic pain. So our traditional therapies looked at, focusing on the symptoms of sickle cell, the swelling, the pain. But now we are looking at other areas. But in the past, we looked at NSAIDs, we have opioids, which we still use, and our adjuncts. Dr. King, I believe, shared a similar slide, but just bear in mind that the pain pathway is a very complex pathway, right? And the pain medication that we had in the past mainly focused on the area of transduction, transmission of pain, and many of the drugs would act centrally, but they wouldn't really do anything to act at the basis of the problem, which is the sickling. So medication in the past, which is what we're going to be focusing on in the first part of the presentation, it mainly looked at treating the pain and the inflammation, but didn't do much to manage the source of the pain, which is the sickling. Causes of acute pain, as discussed previously, you had dactylitis, you had things like acute chest, hepatic sequestration. These were directly related to sickle cell. Pregnancy, as somebody asked, we know that is a trigger for sickle cell. But we also have pain associated but not directly arising from sickle cell, such as cholecystitis, peptic ulcer disease with increased NSAID use, withdrawal from opioids. So yes, that can cause pain, and gout, which we see in our patients that develop renal renal nephropathy. Now, as Dr. King said before, and Dr. Weir also alluded to, patients with sickle cell, especially in childhood, they mainly experience acute pain. But as they get older, you have patients that will tell you, I am always in pain. And there is a waxing and waning of the pain, but sometimes it doesn't truly go away. And untreated acute pain can lead to chronic pain because of neuroplasticity. And that was thoroughly discussed before. But what I want you to get from this slide is that untreated pain can increase risk of depression, anxiety, suicide disorder, and also it can decrease the patient's quality of life. And also, as I said before, patients that have pain, it is the single most predictor of early death. So in terms of chronic pain, you have pain related to the sickle cell, such as acute avascular necrosis, leg ulcers, vertebral body degeneration. You have pain arising, associated but not arising from sickle cell, such as osteomyelitis, loose hip prosthesis, and constipation. No, I don't have to go through this in terms of that, but just to also advise that persons that have sickle cell pain can also have neuropathic pain. And this is not fully understood, but what we know is that there is a prevalence of about 30 to 40% of patients that have neuropathic pain, and it's higher in females. But we know that it's not properly treated. So this slide basically allows us to see that there are several factors at play in the management of pain. We have psychological factors, which I'm not going to go too much into, but just for us to have it in our head, when we are assessing pain, we have to think about a biopsychosocial approach. Pain in sickle cell disease is multifactorial. So if we are going to manage pain, we have to have more than one thing in our arsenal. We can't just hit the pain with pethidine, morphine. We have to think about all the things that go into the experience of pain. In acute pain, that's a vaso-occlusive crisis, which we typically see. It is attributed mainly to the peripheral sensitization, the ischemia, hypoxia, and inflammation. And we mainly use things like acetaminophen, Panadol, NSAIDs, and opiates to manage this pain. But we also have the chronic pain, which is the central sensitization that, untreated acute pain can lead to. And we need to consider neuromodulations. We need to consider chronic lesions. Remember, sickle cell patients can get herpes, and that can also trigger their pain. So when they come with pain, we should be very thorough in how we examine them. We will also look at things like leg ulcers, avascular necrosis, long-term use of opioids. We must consider that when we are assessing and we are treating for chronic pain. Other things that we must consider when we are managing pain is things like depression, anxiety, and sleep disturbances. Sleep and depression play a major role in how patients respond to pain medication. So we must ensure that when we are taking a history, we take a full history of somebody, especially those patients that we label as the frequent flyers. We need to ensure that we do a proper history using the biopsychosocial approach to assess these patients for pain. Now, the patient's pain has the patient's response to pain and their ability to manage their pain. We have to remember that our attitudes play a major role. And everybody in the healthcare system, the porter, the physiotherapist, the surgeon, the primary care, everybody has a role, the social worker. Because if I should see the patient as their primary care, write a prescription, and at the end of the day, it's not available, that impacts on the patient's pain, and that prolongs their acute pain, which can lead to them having chronic pain in the future. So it is very important that we recognize that we are all a team and we are all here for the patient. And if there is no patient, there's no need for us. So we have to ensure that they are central to how we treat the pain, and that they are part of the process. So we're going to move on to how we manage the sickle cell pain using our pharmacotherapy. We must remember each patient is different. Some patients will tell me, boy, doc, Panadol don't work, Cataflam doesn't work, or whatever drug doesn't work. But remember that each person is unique, and there are genetic factors at play. That person may really not respond to the drug. They may not have the receptors. So we must remember that each patient is unique, and therefore we must individualize their pain management. We must take into consideration the 3 Ps, the pathophysiology of the disease, the pharmacology of the analgesics, and our attitudes as healthcare workers. We need to ask about pain and assess it in a systematic way. As I say, it's not a sickler, it's a patient. We need to believe the patient or the family member when they report that they have pain and what relieves their pain. We need to choose appropriate medication, and we ensure that we make the patient comfortable. Don't put them under the AC, make them warm, consult your colleagues, call the unit if you're not sure. Deliver interventions in a timely manner. We need to treat sickle cell patients, because in a way that's just like how we said door to ECG time is 5 minutes, door to analgesic time 30 minutes. We recognize that recurrent untreated pain is the single most predictor of early death. So we need to encourage the patient, empower the patient, educate the patient along with their families. The NICE guidelines in England speak to individual assessment at presentation, primary analgesics in an early fashion, reassessment and ongoing management, look for possible acute complications like infection or some psychological stressor or some environmental trigger like changes in climate. We need to manage those underlying pathologies. We need to look at non-pharmacological interventions, which is going to be discussed by another colleague, And then we need to discharge a patient with appropriate discharge summaries and appropriate pain management plans. So we're going to now go into what are the tools that we have? What do we have in our arsenal to manage sickle cell? We have the pharmacology, which are the drugs. We have physical things like heat, which somebody is going to go through, and we have the education and distraction therapy, which is going to also be explored by another colleague. It is important that you take the history from the beginning, and you want to know about, some patients will say, boy, I have the pain now, but what about the pain that you felt, the sticking? What heralded the pain? Did you have any sticking before? And that is the point you want to let the patient know, that at that point you need to start doing something. Drink more water, keep warm, take a week pain medication. Don't watch it. This watch it attitude gets us in a lot of problems. Empower the patient and to know when to come into A&E, because some people watch it, they notice that they're having pain and they're having 104 fever and they're at home watching it. Problems when they come in, instead of something that we could have just treated as an outpatient, it ends up where they have to go into ICU. It's also important to know that if the patient is being followed up at the unit or by their any primary care, and it is important for you to ask them about their yellow card so you can establish their steady state if they have one. And also be aware of any psychosocial issues. If there's domestic abuse, is there bullying at school? All of those things are important. So our mainstay that we have, the old tools that we have, non-opioids or good old paracetamol or acetaminophen for the Americans, NSAIDs such as our diclofenac or ibuprofen. We have our opioids for mild to moderate pain, codeine and paracetamol, Panadine or Paracoden, Tramadol. We have our opioids for severe or moderate to severe pain, so or morphine or hydromorphone or oxycodone, and these drugs, they have a role in the management of sickle cell, and we must be judicious in how we manage them, but we should not withhold them from the patient because they have a role in the management of these patients. We want to deliver the medication by mouth. So even if the patient is in the A&E, we don't have to see the patient. Sometimes we see these patients with these, no area to sit because they've gotten so much IM injections. We want to manage, if we have access to oral medication, we want to choose those so as to prevent, complications of chronic IM injections. We want to give by the ladder, and we are all familiar with the WHO stepwise approach in the management of pain. We want to give by the clock. So you want to ensure, even you encourage a patient, put it in your phone as I'm supposed to come back in 45 minutes, or I'm supposed to come back in 30 minutes. Put it in your phone so that I can, if you see me, just, remind me so I can come. Never prescribe in the acute phase as needed, because sometimes patients wait on it until the pain goes up, and we are aware from our pathophysiology that this is not something that we want to encourage. We want to treat the pain in a timely approach to prevent chronicity. So these are just some of the mainstay drugs that we're using currently. Paracetamol, just remember some sickle cell patients may have low BMI, and it may benefit us to use weight-based management. So our paracetamol in children or in very thin adults, 15 milligrams per kilogram per dose, Q4 hourly, max dose to 60 milligrams per kilogram per day. We look at our diclofenac. And the doses are there. We can share the presentation. Just bear in mind that this slide is just basically to show you that in order to provide appropriate pain management to our patients, we have to incorporate the knowledge that some persons are thinner than others, and we may need to target the therapy or individualize the therapy based on their weight. So just to go into some of the, Panadol is one of the drugs that is a oldie but goodie, very reliable, very available, and it is still used in the management of mild pain or, in conjunction with some other agents, and it's used at all the steps of the WHO ladder. There is evidence to support that it is effective in treating vaso-occlusive crisis, especially in children, using IV acetaminophen, and it was found in one study that it is effective in the management of crisis. Also, in one study in 2021, it showed that IV acetaminophen may be superior to IV diclofenac for skeletal vaso-occlusive crisis. So that is something to bear in mind. Not sure about the availability of IV acetaminophen in Jamaica, but that is just something to bear in mind for persons that have allergy to, to NSAIDs or to diclofenac. We must also remember that acetaminophen is also associated with the risk of developing renal impairment. So it was thought that, somebody has renal impairment, give them, instead of giving them diclofenac, we give them Panadol. But we are now learning, from this study in 2021 that it can significantly affect persons developing renal impairment. And there's always a risk of hepatotoxicity with elevated doses. So that's why it's so important for us to use a weight bait, especially in persons with low BMI. We go on to our NSAIDs or, our diclofenac or aspirin. And, these drugs have effects on inflammation. It's anti-inflammatory. They are associated, however, with renal and cardiovascular and gastrointestinal toxicities in sickle cell patients. Aspirin may have less renal and cardiovascular toxicity, and the side effect profile is directly related to their effects on COX-1 and COX-2. So we should bear this in mind. And remember, I said that even genetic factors play a role in how persons respond to drugs. So we must remember that individual risk factors and genetic biomarkers should be considered when selecting appropriate NSAIDs and their dose. Persons will come and tell you things don't work. There's a genetic component that really may not work for them. Just to remind us that, when we are that the drugs that and the NSAIDs can affect, the COX system, and it causes the COX inhibition, and at the COX-1 inhibition level, it can cause you to have peptic ulcer and GI bleed. In terms of COX-1 and 2, it can cause foot swelling with sodium and water retention, hypertension. You can have acute hemodynamical kidney injury. We can also have an increased risk of stroke with and myocardial infarction with using these drugs. So that is something to definitely think about when we are giving. They do have a role, as I said, but we have to be aware of these things. I did a presentation at a hospital earlier, and someone asked me about the use of ketamine. And in my research, I found that, it's an old drug. We may use it for gynecological procedures, under conscious sedation. And we have found that there is a role for ketamine. However, it has not gotten FDA approval. And how it works is that it antagonizes the NDMA receptors in the central nervous system, which produces a dissociative anesthetic effect. It modulates hyperalgesia and opioid tolerance in management of chronic pain, in malignancy, in neuropathic pain, and post-operative pain. During sickle cell disease crisis, ketamine infusions have been found to reduce pain in children and adults, and it's usually available by IV or sub-Q or transdermal use, but IV appears to be the best use. We need to be reminded, as I say, when we take histories, we need to be thorough. And the psychiatric history is very important if we are considering ketamine. We know that when persons take ketamine, they can hallucinate. So if the person if it is that they have, there's a suspicion of cognitive impairment, if the person is pregnant, we need to ensure that we take, if it is that they have a history of substance abuse, we may not want to, or if they have schizophrenia, we may not want to consider. Persons that have found this beneficial is persons that are responding poorly to multiple acute therapy, or persons that have reduced quality of life or disability, or persons that have depression refractory to medication or migraines. So just bear in mind that's another one of the weapons that we can use in our arsenal against when we're managing our sickle cell disease. So the side effects, as I said before, hallucination, vivid dreams, and we need to educate our patients of that. Or if they're having unusual thoughts, they should share that it could be a side effect of ketamine. One of the most pronounced side effects is nystagmus, and that can be very scary for relatives. So we should inform our patients of what can happen. I said before, it hasn't gotten to the point of FDA approval, and we are still at the point where we need more randomized controlled trials in order to see if it is that there is a long-term benefit for ketamine. But in the short term, we may be able to use it. Now we go on to our opioids, right? This is Dr. King got a lot of questions as it relates to dependence and addiction and all of that. But as I say, for sickle cell, the pain is the insignia of sickle cell disease. So therefore, we need to, and severe pain, we need, the WHO that is telling us that we need to use opioids for adequate management. So commonly used opioids include morphine, pethidine, fentanyl, codeine, and these are just some of the onset time that is used. We have to recognize that these, depending on the drugs that we choose, some may take longer to work, right? Morphine is a drug of choice, and it's most tolerated in children and adolescents. However, people will tell you, I am allergic to morphine, but this is because it's one of the most histaminergic opioid, which can cause severe itching. It's not an allergic reaction, and we recommend the use of antihistamine. Severe allergy, though, hypotension. So if you're giving morphine, you should be able to do vitals frequently. Bronchospasms, they're telling you to have a tight chest, I feel like I'm wheezing. Laryngeal edema, feel like my throat blocking off. These can occur, but they are very rare. Rare complications also include death, and we should use it sparingly in persons with renal failure. When we're giving IV morphine, the dosing should first be hourly, and then we individualize our morphine. Once an effective dose is established, it should be administered every 3 hours. After 24 to 48 hours and the pain is controlled, we find an equivalent dose of oral medications, oral morphine. When we notice that there is improvement, we need to discharge a patient on sustained release oral medication, and the dose reduced gradually over several days, because we can get withdrawal if we just stop them completely. We give them morphine in remember I said in the beginning, one of the causes of the acute pain in sickle cell disease is morphine or opioid withdrawal. So we may give the patient, they respond in A&E. When they go home, the pain come back, or it's worse because of this kind of withdrawal. Morphine elixir can be used for breakthrough pain. So give them a long-acting medication, and I have some cases, if I have the time to go through of how we go about prescribing morphine, but that will depend on the time. Just to remind persons that, as I said, there are a lot of genetic components and factors that we have to look at when we are managing persons. And if a patient comes in and says, morphine does not work for me, that is a possibility, because we know that some persons are ultra rapid metabolizers of morphine, and some persons are poor metabolizers on morphine. So this may impact on their ability to respond to morphine. Right. Okay. So sorry about that. That brings us to one of our, drugs that right now it's no longer recommended for the use for long-term chronic pain. It's one of those drugs that we really do spare for persons who have a documented morphine allergy, and we have patients like that. So, but this medication, pethidine, as it is a neurotoxin, and it may lower the threshold for seizures, especially with patients in renal with impaired renal function. The analgesic dose for 100 milligrams of IM morphine. So you give 100 milligrams of IM morphine in A&E. In order for the patient to get that same effect at home, they would need 400 milligrams of morphine. Bearing in mind the max dose is 150 Q4 to 6 hourly. So this is the reason why we really don't want to use this drug, because one, it has that potential for addiction. Two, in order to get an equivalent analgesic dose from an IM, we really go way above what is expected for the day. So we want to avoid the use of this drug unless it is absolutely necessary. Bearing in mind that persons with renal impairment is contraindicated, persons with a history of seizures, or persons that are elderly, we want to use other drugs. Now this takes us to the point of opioid tolerance. I'm not going to spend a lot of time on this, but just bear in mind that if you suspect addiction is a medical illness, right? And if you suspect that a person has a medical illness, we want to help them. In the fact is that many patients with sickle cell are not addicted. It's because their acute pain was poorly managed, or they have chronic pain, or they have neuropathic pain, and they may really be displaying pseudo addiction, where they want the pain medication to relieve that pain because the pain was not properly treated. So if it is that we even suspect it, remember, especially those at type A hospitals or even type B, you have the use of the psychiatrist, you have the mental health team refer the patient on the pain clinic or even to us. But don't leave that patient untreated, because it may be worsening their pain and setting them up for an increased risk of death. This slide just basically shows us the analgesic dosing once we are discharging patients. I'm not going to go too deep in this. This is available in our sickle cell care guidelines, but just bear in mind that if we give a certain amount of pethidine, there is an amount of morphine that is required for us to give in order to get that same pain relief. We'll move on to adjuncts. Adjuvant therapy includes things like our antihistamine. Remember, I said that morphine is it releases histamine, so we may need to give our patients DPH. And it also has been shown to potentiate the analgesic effects of our opioids. We have antiemetics like our Gravol. These prevent vomiting, but they may also potentiate the effects of our opioids. We have laxatives. Opioids are known to cause constipation, and we don't want to treat the patient hand pain and they go home with constipation. And constipation can be, very serious and can lead to bowel obstruction. So we need to be aware of that, especially patients that we are treating for chronic pain. There's a role for antidepressants such as amitriptyline in the management of neuropathic pain, and also anticonvulsants such as gabapentin and pregabalin for the management of neuropathic pain. So I'm going to now just move on or disease modifying agents in the interest of time. I was just talking about the old arsenal, but we want to talk about our new arsenal of medication. And everybody likes to ask about cannabis, and the jury is really, it's too early to basically say anything about cannabis. What we know is that we know that our patients are using it. We know that a significant number of patients, I've seen studies that quote from, as much as 40% of patients are using opioids, maybe recreationally or for the management of their sickle cell pain. But the effects of it is conflicting. We have one study that is saying that we have studies that are saying that it may help, but we have a study from Ballas that says that it actually it is associated with higher frequencies of VOCs as opposed to non-users. So we still need long randomized controlled trials to really give an opinion about the use of cannabis, but for now, there's an association with more VOCs. The current treatment, where we look at our disease-modifying agents, we have drugs that are primary treatments and drugs that are secondary treatments. Those that are primary, fall in that group of the primary treatments, are things like hydroxyurea that basically induce HbF. And then we have things like gene therapy, which these are not necessarily drugs, but those are disease-modifying treatments. And many we have bone marrow that is FDA approved, which you're going to see on the other slide. The things that are FDA approved: hydroxyurea, Endari, which I'm going to touch a little bit on. We have Adecvio, which was approved in 2019. We have GBT, which was approved in 2019, and we have our HLA match transplants that's also approved. But we're still in the experimental phase of stem cell, where you actually repair or alter your personal DNA and implant it back. There are many drugs. You can see we have more drugs being researched than we actually have been used at this point. So we have a new arsenal of drugs, and we are hopeful for the day when sickle cell. We have as many drugs as to treat hypertension and diabetes as we have, to treat sickle cell, and we are happy for this. That sickle cell is now being placed at the forefront. Hydroxyurea is. I'm going to spend a bit of time on this. It is one drug that when I came to the unit initially, I used to hear about this cancer drug that was being used, but when I saw children on the drug, and you couldn't tell the difference between the children that were taking hydroxyurea and a normal child, and seeing the vast improvement in the quality of life. I heard Kimon talk, and she's just one of many patients that we have on hydroxyurea. I remember a few years ago we had a there was a shortage of hydroxyurea, and I was a doctor on duty, and the phone rang off. The people just wanted to be on hydroxyurea because they remembered their life before. Especially the parents, they remember their life before. It was a drug that was first synthesized in 1864, and it was previously used for the treatment of solid tumors. However, we have the proof of concept was noted from in 1984, and we see that it's tried and tested. We still have studies going on with hydroxyurea, and I'm so excited about this drug, but it's just how it improves the quality of life for our patients. When we look at the decreased risk of acute chest, decreased need for transfusion, the decreased risk of stroke, all of that, we know that this drug is an effective drug, and we've been using it at the sickle cell unit from 2002. That is 21 years that we are using this drug. So we know that it works, and some of the new things that are coming out says 40% reduction in mortality at 9 years, And it has found many of the studies are done with patients with HBSS and ESTAL, but there is some benefit in concept, and we've noticed some smaller studies saying that it may be beneficial in the management of HBS or other milder forms of sickle cell disease. The standard criteria, once a patient is over 2 years old with a standard genotype, if they have recurrent or severe vaso-occlusive crisis, recurrent acute chest, persistent symptomatic anemia with no underlying cause, such as, for example, renal disease, and even in renal disease, if it's at the early stage, we give it. Non-standard criteria, patients as a secondary stroke prophylaxis in children, or if they have an abnormal transcranial Doppler. Exclusion criteria, I'm not going to give away any answers about this slide. Remember, pregnancy, if it is that a patient is on hydroxyurea and they are pregnant, we take them off because we know it can cross the placenta. If a woman is lactating, we don't give hydroxyurea. Failure to use an acceptable birth control. History of poor erratic follow-up, because we require monthly follow-up initially in the escalation phase, and then when it's established phase, 3 monthly follow-up, or if they have active liver disease. So we start at a dose at 15 to 20 milligrams, and depending on if it is that the person has renal impairment, we start at a half dose. Currently, the drug is about $50 for 100 tablets, and it's on NHF as a double subsidy for children. So sign up your patients for hydroxyurea. If you want more information, contact the clinic. This is just a slide, and this I always call this slide the money shot slide. When we look at the hydroxyurea, and the first slide shows you a person's a little bit of red cells, lots of sickling, and as we go up 8 weeks, 20 weeks, 22 months, we look and we see we have to be straining our eye. We can't even say one sickle cell, and we see the hemoglobin going up. We see our MCVs going up. We know that this drug is working. 21 years, tried and tested. The patient is coming to A&E a lot. Remember hydroxyurea. Some of the common side effects: nausea, increased or decreased appetite, darkening of the skin or nails. Rarely we may see hair loss. In a patients always ask about the risk of cancer, but ongoing long-term studies are needed, as the incidence of cancer is not seen. We have patients on the drug for 21 years, and from my memory, I'm not recalling anyone coming with cancer while on hydroxyurea. So the studies are saying that we need longer studies, but what we are seeing now is that there's no real association with malignancies, even with long-term use. So we have a few other drugs that are FDA approved. Endara, which is L-glutamine, and this reduces the acute complication of sickle cell by working on oxidative stress. It is approved for children 5 years or older, and it is a powder. I'll show it in the picture after. It's an oral administration, and it takes about 2 weeks for you to see any effects. Main side effects: constipation, headache, or nausea. We have this, I get tongue-tied easily, but this drug GBT, we are I'm not gonna try, but this one here, GBT, it reduces anemia and hemolysis in sickle cell disease by inhibiting polymerization of HBS. It's approved for children and adults greater than 12, with the dose is 1.5 grams, and it's given orally. The time for you to see any clinical effects is about 4 weeks. Main side effects: headache and diarrhea. And then we have our monoclonal antibody, which reduces the frequency of vaso-occlusive crisis, inhibits the cell adhesion molecule p-selectin, approved for persons greater than 16 years, 5 milligrams per kilogram, given by IV infusion at 0 to 2 weeks, then every 4 weeks, and you see clinical efficacy at 6 weeks. Main side effects include arthralgia, back pain, and nausea and fever. This drug, L-glutamine or Endara, it has varying availability in Jamaica. It was sold at a few pharmacies and some distributors, but in the last couple of years after COVID, I've had difficulty finding this drug. But it's a powder. Let's say the monoclonal antibody, it is, it's not available in Jamaica, even though it's FDA approved. And I suspect that the cost has a lot to do with it. The cost is about $7,000 to $5,000 US per month for a supply of this drug. So you're looking at about $100,000 US a year for this drug. We look at GBT. It costs about $10,000 US for the year supply of the drug, and we discussed how it worked in the previous slide. Some of the common side effects just shared here. Many of them are mild, but it's just something to be aware of. If a patient should ask, and they are, they have a green card or they're going overseas and they have access to these drugs. So this is our new arsenal. We went from just pain medication to know we.
Hey, Doc. We lost some audio. Can you do me a favor? Oh, see a unmute on the thing? Please just unmute. Okay, you're back now. Just a reminder, we have about 2 minutes left for time.
Right. So just to close off, because this topic is a very, very big topic. What I want to close with is that patients with pain should receive compassionate, safe, and effective care. We want both us and the patient to have the information they need to weigh the benefits of the different approaches to pain, and the goal of helping people is to reduce their pain and improve their quality of life. I'm not an Arsenal fan, Liverpool for life, but we have the arsenal that we can use. So use it and find a winning formula for your patients. Fast track assessment, treat acute pain quickly, aggressively. Don't be afraid to use opioids. Be empathetic to break the cycle of labeling and mistrust. Remember that each person is an individual and not just a sickler, and we want to individualize pain management. Don't always assume that the pain is chronic. Do a full history, do a full examination, and explore other causes of pain. Frequent attendees, especially those suspected of opioid abuse, must be referred on for specialist care to address the root cause of their pain. I thank you very much for having me today. I thank you.
Okay, thank you so very much, Dr. Simmons-Brooks, for such a very interesting discussion on the pharmacological management of sickle cell disease pain, with emphasis on the holistic management of persons and focus on the biopsychosocial approach to managing pain. In the interest of time, I'm going to invite persons to put their questions in the Q&A section for Dr. Simmons-Brooks to answer. Okay, to continue with the program, as most of us can recall, the World Health Organization defines health as a state of complete physical, mental, and social well-being. With that in mind, and with the brilliant setup that Dr. Simmons-Brooks gave, we now turn our attention to mental health and sickle cell disease. To take us through this very relevant topic is Professor Monica Aznani. Professor Aznani is a professor of family medicine and epidemiology and the director of the Sickle Cell Unit of the Caribbean Institute for Health Research at the University of the West Indies in Jamaica. She's a graduate of the University of the West Indies and has been dedicated to the care of persons living with sickle cell disease since joining the Institute over 20 years ago. Her passion is to do all that is possible to improve the quality of life that persons living with sickle cell disease can enjoy. Thank you, Professor Monica Aznani.
Thanks so much, Nikki. It's been a great day, but my anxiety is kicking in because just as I'm about to present, my internet has decided to do its own things. So I am going to close my video. Hopefully it'll work. Let me know, Sam, if you're hearing me because I seem to be frozen.
Yeah, I can hear you.
Okay, great. I'll keep my video off. I'm really sorry about that, and hope we can go through this without much trouble. Let me go into slideshow. Okay, all right, mental health and pain in sickle cell disease. And we didn't do this topic because the Medical Council of Jamaica has just suddenly put in effect that 2 mental health CMEs must be attained by all practicing physicians in Jamaica effective January 2024 when we reapply for our registration. But because it is an absolutely critical area to speak to when we're talking about sickle cell disease on a whole, especially when we're talking about sickle cell. So I want to start with a couple background slides and mental health. So we know the WHO definition of health, Nikki just reiterated that, but mental health is defined by the WHO as a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. It's an integral component of overall health and well-being. And really and truly, it is a basic human right. How many of us have looked at it as a human right? Mental health also lies on a complex continuum and varies among individuals in its experience, difficulties, and distress, and social and clinical outcomes. I put on the CDC definition as well as a Center for Disease Control and Prevention because it simplifies things even more. So mental health by the CDC includes our emotional, psychological, and social well-being. It affects how we think, feel, and act. And it also helps determine how we handle stress, relate to others, and make healthy choices. And on the right, you will see our own Ministry of Health and Wellness's mental health definition, and it mirrors that of the WHO. What's the issue with mental health? Why do we need to talk about mental health? Mental health and mental health problems often come with significant stigma and discrimination. Mental health may come with premature death. Effective treatment coverage for mental health continues to be very low. It's an important area to focus on if global development goals should be achieved. And it's a common problem in SIDS, as small island developing states, of which, of course, Caribbean is a part, with an estimated 15% of the population in the Caribbean and 11% in the Pacific having a mental health disorder. The WHO, World Health Organization, actually has an action plan, a comprehensive mental health action plan, which they adopted in May 2013, adopted by the 66th World Health Assembly, which consisted of ministers of health from 194 member states. This plan was extended in 2019 until 2030 by the 72nd Assembly. And in 2021, the 74th Assembly endorsed updates to the action plan, including the plan's options for implementation and indicators. It's a good 40-odd page read, and I think it's important for us, all of us, to get familiar with it. The 4 major objectives of the action plan, despite all the extensions and endorsements, continue to be the same original ones from 2013, which is more effective leadership and governance for mental health, the provision of comprehensive integrated mental health and social care services in community-based settings, implementation of strategies for promotion and prevention, and strengthened information systems, evidence, and research. Moving gears, and this is really just parroting what has been stated a couple of times today already, led by Dr. Ware, where again, I quote the IASP, 1 in 5 adults suffer from pain. Pain affects all populations, regardless of age, sex, income, race, or ethnicity, or geography. It can have multiple serious sequelae, including depression, inability to work, disrupted social relationships, and suicidal thoughts. There are many social factors that can determine pain. Mental and physical stress at work, you see what's on the top. socioeconomic status, rurality, occupational status, neighborhood characteristics, race and education. And there is shown to be significant correlation between the severity of daily pain and levels of daily financial worries. Those who are really worried every day about their financial health tend to have more severe daily pain. This pain slide, I'm just reminding you, is not just sickle cell pain. This is pain in general. And it is being proposed that pain, as Dr. Ware said, not only to be treated as a disease in its own right, which it should be, but also that it should be declared as a global public health challenge so that it can have the public health interventions that are known to work in other illnesses. Treatment of acute pain remains suboptimal due to various factors, but the most important of these, attitudes and educational barriers on part of us, the physicians, as well as of patients, as well as the intrinsic limitations of available therapies. Inadequate management, though, will further negatively impact numerous aspects of patients' health. So you have pain, which is causing a lot of other social and psychological and other health issues, but inadequate management will worsen those issues and may in fact increase the risk of developing chronic pain. So you inadequately manage acute pain or recurrent pain, and you have a much higher risk of developing chronic pain. And it will further affect the work productivity, impact your quality of life negatively. This figure, I thought, described the various mental and social burdens of having chronic pain. So functional activities will be disrupted, including sleep, work and household chores, leisure activities, energy levels, social consequences with your relationships and intimacy, feelings of isolation, socioeconomic consequences, healthcare costs of dealing with this pain, disability, and of course, lost productivity. Emotional functioning, irritability, anger, anxiety, depression, etc. And it will affect patients' level of activity at all areas of their functioning, work life, home life, school, social life, etc. And psychosocial factors can influence risk of development of pain, pain-related adjustment that is needed long-term, as well as modulating pain outcomes. So you see how the interplay occurs between pain and psychosocial issues. So again, Dr. Ware spoke to the biopsychosocial model of pain, and this approach really to understanding pain has been identified as the most successful model to date, as it is in really understanding the impact of any kind of chronic illness. Pain emerges from a dynamic interplay between biological, psychological, and social factors, which will vary between individuals. And these factors, the biological, the social, the psychological, are not mutually exclusive. Associations between pain and psychological distress and other social problems tend to be bidirectional. And factors that promote resilience, such as emotional support systems and good health, can promote healing and reduce pain chronification. Focusing attention on malingering as a contributing factor is not compatible, is not stated to be compatible with this model of understanding pain. And because of the biopsychosocial nature of pain, personalized, multimodal, interdisciplinary treatment approaches are likely to be more successful. All right. So let's talk about, move on to sickle cell disease management. Some of the overwhelming issues within sickle cell disease itself. We've said a lot about the disease already this morning. So we all know it's a genetic disorder, right? And many times it is actually a monogenic disorder, which means it's a single gene defect that leads to this vastly complicated problem, right? But it has multifactorial etiology. So you see the biological, this is a schema that we put together to try to improve the understanding of the complex interplay of various factors, the psychological, the clinical, the behavioral, the socio-cultural. What we haven't spoken a lot about are the structural factors and the environmental factors, which will affect all your outcomes in sickle cell disease. Sickle cell disease is a chronic illness, right? We know what a chronic illness is: hypertension, diabetes, asthma, cardiac disease, etc., cancers, HIV. But if we look at sickle cell disease as a chronic disease, which it is, because we've said already today that, persons who are born with this disease from as early as age 4 to 6 months can have start having complications of this disease, and throughout the life course will have various and varying presentations and problems and complications. So we need to employ the chronic disease model in managing sickle cell disease, and it is a severe illness. And we all need to understand the mechanisms and the underlying factors that will impact outcomes so we can really do a good job in this management. We have said this many times: pain is a hallmark of sickle cell. Pain is the commonest reason for A&E visits in sickle cell. Pain is the commonest cause for hospitalizations. Sickle cell pain is also the reason for the highest 30-day readmission among all sickle cell diagnoses. And the last bullet point I want us to look at: opioid-related deaths in Blacks with sickle cell disease have shown no increase despite the opioid epidemic in the USA and the related increase in opioid deaths. There have been a couple of problems in the overall management of sickle cell disease, or a couple of problems that have impacted management of sickle cell disease, and ethical and many other injustices have surrounded sickle cell disease in multiple areas. There have been many disparities in clinical and psychosocial outcomes because of these inequities and injustices. Funding for research is commonly known that sickle cell disease really tends to be at the bottom of the totem pole for funding. I ask us in the Research Institute who have to struggle to find funding. As well, there are inequities in health system responses when compared to those in other chronic illnesses. We are a bit luckier off in this area in Jamaica with the engagement of Ministry of Health and Wellness in sickle cell disease care in the island. So all of these inequities are, examples. Less access to comprehensive care. We still are struggling to get up there with that. Fewer sickle cell disease centers are available. These are global. And there's gaps not only in research funding, but also in implementation of clinical advances. Not every country in the world can boast of newborn screening that we now have in Jamaica for sickle cell disease, or penicillin prophylaxis, which we know will save lives and has led to sickle cell children in Jamaica having the same lifespan or no worse outcomes than any other baby in Jamaica born without sickle cell disease. Many of the inequities in sickle cell disease are considered are because of racial issues. Sickle cell disease being considered a Black disease or a minorities disease. Yet for us in the Caribbean, we do not really expect these kind of racial biases to play much of a role in the management of persons living with the disease. And some of the problems that have been identified, and we're going to do a whole panel on this in the management of sickle cell disease, pain in particular, is the implicit bias, and implicit bias is that occurs unintentionally, but does affect our decisions and behaviors. For example, misperceptions that persons with sickle cell disease are drug seekers, health-related stigma, devaluing individuals due to the presence of a health condition. I remember when I came to the unit earlier on, sometimes we had to say to our patients, don't go to an A&E and the first thing you say is sickle cell, even though it should be the first thing you say, because chances are your docket might reach the bottom of the pile instead of top of the pile. Unease with prescribing powerful analgesia. I heard Dr. Simmons-Brooks say, please do not be afraid to use opioids. Learn how to use opioids. Do not be fearful of the risk of addiction, which really has not been shown to be a major problem in most persons living with sickle cell disease. Medical mistrust on the part of the patient because of all of these issues that they have grown up facing are some of the few of the problems that make problems with managing sickle cell disease. So let's move right on to what happens with sickle cell disease and mental health. So sickle cell disease can lead to many, many stressors, complications of sickle cell disease, especially the unpredictability of severe pain events. disruptions of normal life activities, missing school, the social isolation it can lead to, inability to participate many times in tasks of daily living, need for repeated hospitalizations, the fear of death, right? These are a few of the stresses, but we know when it comes to pain, and it was highlighted already, going into some major exams, right, can bring on painful crisis. Having the loss of a loved one, having a breakup in your intimate relationship, oncoming menstruation, these can all be stressors that can lead to a painful event in sickle cell disease patients. So there are many sources that exist. What are some of the mental health and social issues that occur in sickle cell disease itself, not just in those with pain, but this is the underlying mental health issues that persons living with sickle cell disease face over their life course. Social isolation, I've said this, I think, about 3 times already. There's a much higher level of loneliness that is experienced by people living with sickle cell disease, because guess what? Even their families, communities, and loved ones may not fully understand the kind of life that persons with sickle cell disease have to lead at times. A lot of them complain of a loss of control of self, a helplessness. I cannot control what's happening in my own body. The disease takes over my body, the unrelenting pain, and the fact that it can be, you really cannot, you get up fine, excellent this morning, and you're ready to go, jump up and go to school or go to work, and an hour later, you're having the worst pain ever. The significant experience of stigma that these persons face, and really persons with sickle cell have described that those who are living with less or lower socioeconomic status, which in itself is a social problem, which impacts outcomes. Stigma is experienced worse in those with less, and those who have more severe disease are living in higher poverty. So you see once again the interplay and the interactions. There's much higher levels of depression, higher levels of anxiety. Girls have poorer quality of life, and this is worse in females, both girls and young women and adult women. Those with higher levels of education tend to have better quality of life. They tend to have better knowledge of their disease and hopefully better outcomes. Within our own setting, this is our local data, depression in various studies. 20 to almost 30% of persons living with sickle cell disease had depression or depressive symptoms, more in women, less depression in those who had more friends or social support mechanisms. Suicide attempts much higher than in the non-sickle population, over 10%, much more in females. Those who are not employed are more likely to be depressed, again, an interplay between mental health issues and social issues. Those with more frequent painful crisis, or those who visited the unit more frequently, are more likely to be depressed. And those who had higher external locus of control, which means other factors, I do not have control over my body, but external factors have higher control over my body, also had significantly higher levels of depression. Even within teens, we saw risky behaviors for whatever reason we still need to understand, but more sickle cell disease teens were using alcohol, almost 70% usage of alcohol, and many other risky behaviors. We did find that risky behaviors were less in those teenagers who were living with a parent or those who were currently in school, meaning having stronger support networks. Sickle cell disease teenagers especially also had negative body image. From one of our qualitative studies, these are some of the quotes that I thought could really express much better than anything I could say of what it is like living with the disease. Respondents were frustrated about the lack of control. They were at the mercy of uncontrollable, easily triggered episodes of really unbearable pain. And a rural female states, sometimes you don't have to be doing anything. You may be relaxed and it just come in like it say, yeah, it's my time now. Faced with these challenges, some respondents suffered from depression. This was most likely when they were in the midst of a painful crisis. Some even exhibited suicidal ideation. Again, another rural female who says, "Me see some things will lick me, that hit or knock me down." This was for the purposes of the journal. And me say, "It na make no sense me live." Structural factors also have a strong influence on coping. Lack of resources, stigmatization, racism, sexism, and disableism can complicate how people experience their sickle cell disease. Moving closer to sickle cell disease, pain and mental health. Sam, a sound check again. Am I being heard or only speaking to myself?
No. You're talking to us and it's wonderful.
Thank you. It's just my very unstable internet I'm worried about. Thank you. Okay, so pain and mental health. Recurrent vaso-occlusive crisis, otherwise called painful crisis, can lead to many psychological problems. Again, repeating depression, anxiety, poorer quality of life, and it's worse in those who are depressed and anxious as well. Many sleep problems, loneliness, and mental health problems themselves will exacerbate acute pain events. I think Dr. King mentioned some of these, and these are our own local studies. Those who had neuropathic pain stated that they had reduced emotional and social functioning. And those who had chronic pain had reduced functioning in all 5 domains. This is based on the Ask Me, the sickle cell quality of life inventory. They had reduced functioning on emotional, social pain, and social functioning scales. Depression associated with frequent pain crisis. Those who had frequent pain crisis had 2.5 times the odds of being depressed than those who didn't have frequent pain crisis within sickle cell disease. And persons who have recurrent pain had higher catastrophizing, and those who use catastrophizing tend to cope very poorly with the pain as well. The Pisces study is a landmark study out of the US. Wally Smith and his team conducted this many years ago. It's the pain and sickle cell epidemiology study, really examining the epidemiology of sickle cell pain, where they examined prospectively a cohort of 308 sickle cell adults. They did daily diaries for up to 6 months. And some of the results are as these. Depressed subjects, those who were found to be depressed through their daily diaries, had pain on significantly more days than those who were not depressed. Those people who were in pain, but on non-crisis days, so they weren't having crisis level pains, but they were having pain. Depressed subjects had higher mean pain scores, higher distress from pain, and higher interference from pain. Persons who were anxious also had higher pain scores, higher distress, and higher interference. And those who had depression and anxiety had poor functioning on all quality of life subscales from the SF-36 quality of life measure. This work, this study I thought was really, really interesting. And this is from Tom Coates' work. He's done a lot of physiological studies with pain and vasoreactivity, etc. And this study says that the consensus from patients and their families is that pain crises most often occur after experiences involving mental stress, anxiety, exposure to extreme temperatures, or pain itself. So, and they showed in very elegant experiments that stress led to increased pain intensity through modulation of the autonomic nervous system activity, which impacts regional blood flow. Experiments that examined the autonomic nervous system, they looked at the ECG, the R2R interval, and heart rate variability. They looked at microvascular blood flow activity through photoplethysmography, secondary to stress, the microvascular blood flow, secondary to stress situations, and they examined the stressors using the state trait anxiety inventory questionnaire, and they use pain anticipation, memory task, and conflict task. So it's a complex experiment, but it's really worthwhile a read. And you can see that this was at baseline. These were the microvascular blood flow at baseline, pretty higher up. But once they got the stress tasks, the NVAC, the stroke test, and pain anticipation, their microvascular blood flow had significant reductions, right? And we know that vasoconstriction and decrease in blood flow is one of the main pathophysiological mechanisms behind sickling and sickle cell crisis. So they concluded that mental stress caused neural-mediated vasoconstriction and autonomic nervous system reactivity in all subjects in their experiment. I think, if I'm not wrong, they examined about 40-odd persons in this study. So really a very elegant experiment to showcase how stresses might lead to pain. And we're just not imagining it. We don't have to say that the patient is imagining it. Again, another study, this is by psychologist Karen Gill, who has done quite a bit of work in sickle cell disease. She and her team examined daily diaries among 37 adolescents, and these are now teenagers, which reported pain, mood, and stress. They looked at positive affect, negative affect, and they examined stress. They just asked perceived stress on a 100 millimeter visual acuity scale, from not at all stressful to as stressful as I can imagine. And the results were as follows. On a day-to-day basis, increases in stress were significantly associated with increases in pain. So the days that these teens said they had higher stress levels, they had higher pain levels. Increases in negative mood were significantly related to increases in pain, whereas increases in positive mood were associated with decreases in pain. Increases in pain were related to more school absences and reductions in extracurricular activities and household chores. They just couldn't manage to do that much. And stress and negative mood themselves were also associated with decrease in activity, whereas positive mood, even on days that they had pain, seemed to help these children to maintain school attendance and activity participation. Sickle cell disease pain and other pain predicted higher levels of stress and lower levels of positive mood, even on subsequent 2 days following the day of pain itself. So it's a lot on the slide, but I hope you're getting a feel for what I'm trying to say. Next 2 slides, because stigma is social, has social and psychological complications and outcomes, I thought it would be remiss not to speak to this very quickly, even though I am positive that the barriers panel coming up later today is going to really speak to this. But stigma will have impact on pain management. We spoke about the implicit bias. Persons seeking pain relief are being stigmatized as drug-seeking, drug addicts, frequent flyers. And this is really just terrible. Terrible. And ask sickle cell docs who manage this illness day in and day out. If we do not understand the mechanisms behind pain, then it is our ignorance. It is not the person seeking pain relief that we are labeling and then kind of taking out our frustrations of ignorance on them. Their experience of pain are being discredited, and the commonest issues that studies think led to stigma was patient behavior in many instances. But we have spoken today about the many areas why a patient's behavior might not be exactly what we think we want to see in our clinics and in our offices, because sickle cell is a vast and can be a terribly ugly illness. The opioid epidemic has led to worse stigma, concerns about addiction, stigma around sickle cell disease itself, the racial stigmatizing, etc., and the provider attitudes. And stigma will lead to, these are studies that have shown stigma leads to delays in treatment delivery. Studies have shown that sickle cell patients in pain have longer wait times than anybody else, another Black person attending the same A&E for some other painful event, non-sickle person, but assigned the same triage level. There's underdosing of opioids and just generally poor sickle cell disease pain management. Stigma leads to hesitation on part of persons who live with the disease attending for care. A lot of persons say, I don't want to go to the hospital. I don't even want to tell my family that I'm having another pain crisis because I'm not going to be believed. And that leads to delays in care seeking with real poor outcomes. Persons with pain who experience stigma have maladaptive coping and greater pain catastrophizing. So, and healthcare providers, we have said earlier, are not the only source of stigma. It can come from their families and their communities, schools, workplaces, etc. Last couple of slides, what's my time check, on addressing mental and social health in sickle cell disease pain. And the main considerations are as follows. These are the major prerequisites, and these are just a few of them. I'm sure there are many others that you can think of, but major prerequisites for an effective and rational management of sickle cell pain relates to the patient, including the psychological and social factors that may be unique to that patient. We have to understand the pathophysiology of the disease. We have to understand the pharmacology of analgesics. I'm seeing in the chat and in the discussions, people who have allergies, people who are not responding to morphine, etc. And very importantly, the attitude of us, the healthcare providers. These are all prerequisites to consider for effective pain management. And if we are to optimize the management of pain in sickle cell disease, multidisciplinary care is needed. Here are various prongs that are shown on this schema, and you will see community resources and support, social support and services, the need for a sleep specialist. Look out for other pain conditions that may coexist with sickle cell patients, etc. Pain specialists might be needed, and thank you, KPH, for offering the support. University of the West Indies Hospital also has a pain clinic, and there may be other pain services, mental health services, care coordinators, etc. So it's multidisciplinary care that is needed to effectively and optimally manage pain. Again, from the same study that I showed earlier, these are some of the coping strategies that our very, very good Jamaican patients highlighted, their own coping strategies, cognitive and behavioral, that they used, engaging support, particularly from family and friends, especially during a pain event. And an urban male states, one of the greatest things is that I have people around me that do care, caring and informative staff. Nowhere else that could understand sickle better than this clinic. They are referring to the sickle cell clinic. And this is another urban male. Acceptance, a number of our Jamaicans say you just have to live with it and move on with it. Mental strength was key to maintaining physical health. Being depressed or stressed would make them sicker. So a rural female says, "Me not try for hackle up myself because that send on the pain too. I try not to." Faith in God, this is a big one, especially countries like ours where religion plays a big part in our social lives. A rural female says, "I just talked to my father and say, God, you know the reason I'm not a doctor now." She wanted to be a doctor. "I'm not going to question you and say, why should I, why me, and whatsoever." Distraction, and this is so often misunderstood by healthcare providers, but distraction is a big technique, a big strategy that a number of persons with sickle cell disease use for managing their pain. A rural female says, "Me just don't put it on my mind. It's not like me forget that me have it, but me just don't sit down and think about it." She's talking about coping with sickle cell disease, but a lot of our sickle cell pain presentations use distraction as well. They listen to music. So you know, Mark, we really need to examine that, and they do various other things to distract themselves from the pain. So it's important that we pay attention while we are trying to manage pain on improving social and mental health of persons living with the disease. Always assess for coexisting psychological and social problems when a person presents to you, just like in other chronic diseases, you know, we especially in sickle cell, which is a lifelong disorder, we need to be doing routine screening for depression, for anxiety, especially persons with the lower socioeconomic backgrounds, the problems worsen. We need to be continuously educating patients and their families on the positive effects of parental support, continued social activities, continued school attendance, reduce the social isolation, reduce their feelings of loneliness, which will worsen their sickle cell pain. Cognitive behavioral therapy so far is probably the only technique, and we are going to have another talk after this on non-pharmacological treatments in sickle cell pain, but CBT shown to be effective in managing sickle cell pain. And other coping strategies that have shown some use and benefits are distraction, religious beliefs, and faith in medical providers. But yet, on a whole, evidence and efficacy of psychological therapies in managing sickle cell disease and in managing sickle cell pain are still limited. And we do need to continue research efforts and further testing of interventions on how they affect pain experiences and pain management in sickle cell disease. So I will stop there. Thank you so very much for listening.
Thank you for sharing this very relevant topic with us, Professor Asnani, and for highlighting the research supporting the importance of the bidirectional relationship of mental health with sickle cell disease pain. We can now have 4 minutes to answer a few questions. Hopefully someone has posted.
So there are a few questions. They were being answered while we're off. There is one interesting one here, Prof. From Cashel Williams. Is a fentanyl patch safe therapy for chronic pain in SCD?
It is a safe therapy. Fentanyl is also available. I don't know what COVID has done to availability of most medications. Can you hear me? Yeah.
Yes.
So fentanyl is safe, but it would have to be managed properly by your healthcare provider. But and I think I'm not sure if Dr. Simmons-Brooks spoke to fentanyl, but yes, it is a safe medication to use once it's under care of your provider.
Thank you very much.
Sean Taylor, who is a person living with the disease, says music therapy works very well. So we really need to be listening to our patients while we go on to explore what interventions can work more widely in our sickle cell community.
Agreed. Thank you.
Yeah.
Thank you so much. Agreed. All right. So not seeing any more questions at this time. I do, however, see a comment that says fentanyl patches are now available and they're in the NHF system.
Thank you, Dr. Spencer French.
All right, back over to you, Dr. Chin.
Okay, ladies and gentlemen, I now invite you to listen to a gentleman with sickle cell disease discuss his experiences from childhood to present. This will be followed by a word from P.A. Benjamin and a short video from Stanford. Thank you.
I'm Orville. I'm 60 years old and I've lived with sickle cell disease all my life. Needless to say, it comes with pain. I'm straight SS, and although not knowing what sickle cell was in my formative years, I had the pain. My parents were told I was a sickler, and to them it just simply meant that I'd get sick easily. So I was prevented from going into the rain, or when they were around, I wouldn't be allowed outside to play with all the people that I knew or all my neighbors. I was restricted to staying inside because I'd get sick easily. My pain was usually my ankles. My ankles would pain ever so often, possibly at least once a month or so coming up. My dad loved the beach. He grew up in a seaside village in St. Mary. And so when he came into Kingston, he always took me and my siblings to the beach. My first encounter with the pain was that I would go to the beach, stay an extended time in the water, and my ankles would just be in excruciating pain. At that time, I thought it happened to everybody. I thought, I just got it quicker than anybody else because they say I'm a sickler. But I figured that if they stayed in the water long enough, their ankles would pain too. The pain was like, it felt like the bone was broken. You can't put any pressure on it, and the least of pressure on it, it would sting, and it was very excruciating. And back then, there was no real pain management in my appearance, so I'd have to tough it out until that pain go away all by itself. The next thing was my knees. In possibly sometimes, if I was in school or so, probably under a stressful environment, I'd have pain in the knees, probably exam time or thereabouts. With some form of stress, it came along. And again, it felt like your knee broke and you just had to stay with that pain. It usually is a sharp pain. I know back then when you went to the doctor and they said describe the pain, they always want to know if it's a sharp pain or it's a dull pain. And it came in all varieties. It started out dull, and then it became very sharp, like something was piercing you in there. I'd always tell them, like, it's like a spear, and somebody push it inside of your knee. The same shock sensation when you put pressure on it, and it hurt. In my days, again, you didn't know to hydrate, to drink a lot, and I would go about my business until it wore off. It could take a day or two, or sometimes it would take a week or so, and you just have to tough it out. The major pain, of course, was my chest. That entailed a pain somewhat like when you get stitches. You exert yourself, you probably just suddenly start running without warming up, and you get that stitches pain in your side. It's somewhat like that, and it usually starts out on one side of your chest. All of the bones, the pain is inside the bones, and at that time, with every breath you take, it's just that sharp pain that you're greeted with. So at that point in time, you don't want to take a deep breath, or you restrict the breath. You put a pillow over your chest, and you try your best not to expand that chest cavity, because here, in expanding it, that you get that sharp jolt, and it's very excruciating. you can't find a comfortable spot.
All right, that was the end of our video. Thanks so much to Orville for sharing. We're now going to hand over to PA Benjamin. We'll have a presentation. Hi, Lisa Ann. Go ahead.
Hi, good afternoon.
Afternoon.
Share. Good afternoon, everyone. My name is Lisa Ann McGill, and I'm a medical representative at Facing Commodity Limited. And today, I'll be representing the Benjamin's Pharmaceutical Division. As you know, the cough and cold season is quickly approaching, so you'll find that a lot more patients will be coming to you seeking a relief for their symptoms. And one of our most popular products on the relief line to combat cold symptoms and the persistent cough is the Relief Cough and Cold. It has ammonium chloride, chlorpheniramine, pseudoephedrine, and sodium citrate. This combination makes it the ultimate relief product for coughs, nasal congestion, sneezing, itchy, and watery eyes. The Relief Cough and Cold is perfect for the entire family, and it's also very affordable. The Benjamin's Relief Elixir is our only product with solely diphenhydramine, which is an antihistamine that will aid with managing the side effects of medication, and it's perfect for allergies and runny nose. It is also sugar and alcohol free and perfect for the entire family. And it also comes in 2 additional flavors such as cherry and grape. Now, pain is a common problem for children with sickle cell disease. The children's relief fever and pain with acetaminophen is fast and effective for bringing relief for that pain alongside with immunization pain, toothache, muscle aches, and etc. As you know, children are picky when it comes on to taste. So they appreciate the taste of the relief fever and pain as it comes in cherry and grape, and is also safe for children 6 months and over. In addition to the management of pain, we have the Benjamin's Blue Eyes Deep Cooling Pain Relieving Gel. Now, this product is a topical viscous gel that contains 3% menthol that aids to relieve painful joints and aching muscles. This product will provide a cooling sensation that many patients find soothing, and because menthol is a known penetration enhancer that allows other chemicals to penetrate deeper into the skin, it allows for a faster relief of pain. Now, what if I told you that we have a product that works faster than a hot cup of tea? Because as Jamaicans, we love tea. We drink it morning, noon, and night. So let me introduce you to the Benjamin's Antacid Anti-Gas, which contains aluminum hydroxide, magnesium hydroxide, and simethicone, which aids to neutralize stomach acid, which results in the rapid relief of stomach gas, heartburn, indigestion, and hyperacidity. This product also tastes great because of its peppermint flavor, and it's also safe for diabetics because it's sugar-free and it's also very affordable. So when your patients are seeking that quick relief, don't forget to write the Benjamin's Antacid Anti-Gas, Benjamin's Blue Eyes, and the Relief Line, because again, all you need is relief. Thank you so much for your time and attention. Do enjoy the rest of your day.
Thank you. Having previously heard about the pharmacological management, we now turn our focus on non-pharmacological strategies in the management of sickle cell disease with Dr. Deepika Darbari. Dr. Darbari is a pediatric hematologist-oncologist at Children's National Hospital and the professor of pediatrics at the George Washington University in Washington, D.C. Dr. Darbari studies complications of sickle cell disease with emphasis on pain. She has been conducting clinical and translational studies directed towards better understanding of mechanisms of sickle cell pain and its management using pharmacologic and non-pharmacologic integrative modalities. Her research has contributed to improved understanding of variability of pain experience and risk factors associated with high pain burden in patients with sickle cell disease. Her team has described changes in brain connectivity and volume associated with pain in patients with sickle cell disease. She has also contributed to development of diagnostic criteria for acute and chronic pain in sickle cell disease with the American Pain Society, and more recently developed a FENX toolkit for pain in sickle cell disease. As an active participant of diversity, equity, and inclusion efforts at Children's National and the American Society of Hematology, ASH, she is also committed to promoting diversity in medicine and hematology, especially as it relates to trainees from underrepresented in medicine background. Her efforts have been recognized by the 2021 ASH Honorific Award for Leadership in Promoting Diversity. I now turn over to you, Dr. Darbari. Thank you.
Yeah, hi, good afternoon, everyone. Can you hear me?
Yes.
Okay, great. And so thank you for the invitation. Actually, I'm traveling, so if there's internet, is unstable, please let me know that if you cannot hear me or my slides are not moving or anything like that.
Okay, no problem.
So let me see. So these are my disclosures, but my talk is not related to these topics. So today I'm going to talk about integrative methodologies in sickle cell disease and our experience, and this is the outline for today. I'm going to briefly talk about pain in sickle cell disease, acute and chronic pain in sickle cell, what are some of the challenges that we experience and how we can use non-pharmacologic strategies and initiative that we have been using. So as we know, sickle cell disease is a chronic condition. It involves pretty much any organ system, but pain, as we heard today, pain remains the most common complication of sickle cell disease. And as we heard from Dr. Asnani's talk, it can start as early as 6 months of age. There are multiple psychological comorbidities that can coexist and can result because of high burden of pain. There's significant direct and indirect caused, and also it is known that individuals who experience higher burden of pain, they have shorter lifespan. So it's important to understand all pain is not same in sickle cell disease. So there are multiple ways pain can be classified, and we know the most common kind of pain that we see our patients coming into the hospital, which is the acute pain, also known as crisis pain. As the patients get older, the frequency of pain increases, and a lot of patients, high significant number of patients, develop chronic daily pain. And they start to occur in preteen years or teenage years. And the definition of chronic pain is if a person is having pain more than 50% of the days in past 3 months or so, that is called chronic pain. And the third kind is acute pain that occurs on the background of chronic pain. So the patient may have chronic pain, but they have the episode of acute pain on the background of chronic pain. This is the slide. I hope you can see my cursor, but slide here shows pain days proportion of patient, and what were their pain intensity. So as you can see, that as patients get older, the frequency of pain is much higher, and I'll show that in a second again. We also know that when we see our patients in the hospital for the acute pain, that pain actually just represent the tip of the iceberg. So patients may experience, when we see in the hospital, which is the top line here, 3.5% utilization of healthcare with or without crisis. So up here, but there are many other days when patients may experience pain but may not come to the hospital. And as I mentioned, the burden of pain increases with age. So as you can see here this is the discharge data showing how does it change, the burden of pain changes as patient age. So as you can see on the left side is the age group, so less than 1 year of age, and then also different age group. And as you can see, 60% of the discharges were between patients who were 18 years to 44 years of age. So they were, that was the highest burden of pain. And also length of stay, as you can see here, average was 6 days. And lower down here, you can see, and what we think may be happening, because when the patients are young, their pain is primarily vaso-occlusive kind. So they have occlusion of the blood vessel, they have pain, and then we treat them and their pain gets better. But as patients get older, especially as I mentioned during their teenage years, other mechanism of pain start to play a role. So instead of just pure vaso-occlusion, they may develop bone injury. They may have avascular necrosis of hip that contributes to pain. There could be because of the exposure to opioid. There may be, opioid-induced hyperalgesia. There may be neuroplasticity or other sources of pain, as you can see here. So in young patients or young children, we see they have acute episode of pain, and between 2 episodes of pain, they may have pain score of 0. But as the patients get older, in between the pain episodes, the number of pain or the intensity of pain may not come down to 0. So there are different guidelines for managing pain in sickle cell disease, and I list here ASH 2022 guidelines for sickle cell pain, and also looking at the non-pharmacologic therapies that has been recommended for sickle cell pain. As you can see here, that most of the recommendations were conditional, and they were based on very low certainty of evidence. And so in fact, we really cannot say there are good studies showing that the non-pharmacologic therapies were effective or not, when can they be used. And also, as you can see here, for children, there were no recommendations. So that also causes a problem because, as you know, as kids become older, the risk of chronic pain increases. So it's important to use any of these modality at younger age so we can prevent development of chronic pain. We also know that pain management is sickle cell disease is not adequate. We know that this is the #1 cause for hospital admission. So over 75% of admission are related to pain in sickle cell disease. And as you can see in US, that number, the cost of sickle cell pain management is close to $1 billion now. There are multiple reasons why patients may be staying longer in the hospital. And despite that when they leave hospital, they may still have pain. And chronic pain actually is a big challenge because that it's treatment refractory. We can continue to increase the dose of the pain medication, but pain may not get better. So it's important that we develop strategies so that we can prevent development of chronic pain. And why is chronic pain so difficult to treat? So in this situation, many times we see patients have high burden of pain, but despite getting high doses of opioid, they may, it may not be working. Their pain may remain same. Patient may start to experience side effect of opioid without any benefit. And as we know, the chronic use of opioid can also contribute to increased sensitivity to pain, as we call opioid-induced hyperalgesia, and also central sensitization. So all stimulus may contribute to the experience of pain. And then, so this chronic pain is not only difficult to treat, it also impacts the treatment outcome related to different modalities. And we have seen that even in patients who have received bone marrow transplant, if they developed chronic pain, their chronic pain or their pain may not go away for up to a year or so. So the point here is that chronic pain is really very difficult to treat once it's developed. So there are many challenges. And why is it so challenging to manage pain in sickle cell disease? So first of all, pain experience is subjective. So we don't have a biomarker that can say like, oh, a person is in pain or not. And it becomes challenging for young individuals as well. And it's also impacted by multiple factors. So experience of pain is impacted by many factors, as you heard earlier in the talk. There may be psychosocial factor, there's mental health comorbidities, and what else is going on in person's life. All these can impact the experience of pain. Mechanism of pain are poorly understood. So we know there's acute pain, there's chronic pain, and there's acute on chronic pain. But what leads to the transition from acute to chronic is not clear. There are many etiologies of pain, as I mentioned. Treatment is primarily symptom-based. So if a person has pain, we really treat the symptom of pain. We try to treat based on etiology, but many times it's unclear. And when we manage our patients, many times it's just like treating the symptom of pain or sickle cell. So it's not really patient-centered. Our management is primarily opioid-centric, or just using pain medication that may have different side effects. And especially in case of opioid, there's concern for tolerance or dependence, and also loss of efficacy. So we may continue to go up on the dose of opioid with not significant benefit. There are limited non-opioid choices. So even if we tell a patient, okay, we are not going to, opioid is not good, you should not be using it, but what do we offer them? So we have very limited choices. And also when it comes to limited non-opioid therapies, lot of limitations there. There are certain non-pharmacologic adjunctive therapy, but as you heard, there's limited research in this area, and many of those, at least in US, may not be covered by the insurance because there's no evidence. And if a person is on high doses of opioid, and again, it's based on my experience here, if a person is on high doses of opioid and would like to go to rehab with the purpose of opioid wean, there are long wait times for a patient to get in the program. So clearly, my purpose of showing all these slides were clearly we need some new strategies that we can manage, but more importantly, prevent the development of chronic pain. So looking at all these at our institution, we started a clinic called Sickle Cell Disease Integrative Clinic. And it was most of the individuals who were participating in this clinic were really volunteering their time. And this program included volunteers from hematology, from anesthesiology, palliative care, psychology, physical therapy, and also pain medicine physician. And our goal was to see, would our patients like this or not? So before I discuss our experience, I want to clarify, you hear many times, we hear this term, it's a complementary medicine, alternative medicine, or integrative medicine. So what does that mean? So alternative is when a patient or a person's non-mainstream approach. So for example, the person says, I'm not going to take hydroxyurea, but I will use this herb. So we don't really support that because we don't have any evidence showing this other medication or other herb that will be used in place of hydroxyurea is effective. So that's alternative. Complementary is when this non-mainstream approach is used along with the conventional medicine. So if, for example, a person uses hydroxyurea, but also uses physical therapy or relaxation or things like that, that is called complementary. So they are used together, not in place, one in place of other. Then the third thing what we promote is called integrative health. So integrative health is, it brings conventional and complementary approaches together in a coordinated way. It emphasizes multimodal intervention. So like, for example, a person having sickle cell disease or ABN or chronic pain uses hydroxyurea, but also uses physical therapy, acupuncture, or yoga to increase the flexibility and things like that. And it emphasizes on treating the whole person rather than one organ system. So it's not just we are treating sickle cell disease or anemia, but what is important to that person. So as we know, not just for sickle cell, so this data is not for sickle cell, but it shows that there's increasing interest in these modalities. And people have been using deep breathing, natural product, and things like that. You can see on here, massage and other special diets for a long time. And on the left side, you see what are the common reasons. These have been sleep, pain, mood disorder, stress, anxiety, etc. So the data from the NCCIH showed that, complementary approaches have been primarily used. They looked at which individuals or which population is really using. So in US, the patients were primarily older patients, 45 or older. These were females, mostly white, and they had private or public insurance. So this was not really our population that we were seeing in our clinic. So we wanted to see, would there be interest in our patient population, that is children with sickle cell disease who are seen in our hospital and primarily coming from African ancestry, would they be interested? So Lisa Daniel, as you see highlighted here from our institution, interviewed our patients and saw and asked this question: are you using any of the complementary or integrative approaches? And are you open to that? So it turns out 85% of children, so if the parents were interviewed or if they were adult, we interviewed children or young adults, they were mostly using some of these approaches. So then we wanted to see, and at this time, we also have started to use acupuncture for our patient and also some of the integrative approaches. So wanted to ask our families, what did they feel about it? Did they like this approach or they didn't like this approach? And as you can see here, our patient population, their parents, they really liked it. So over 90% liked the procedure, those were offered to them. And I'll talk about which procedures we offered. Close to 90% had positive reaction, and they would recommend it. Most of our patients said they would recommend these approaches, and they believed these were effective. So based on that, we went to our foundation and asked for some more money to support this initiative, and we were given some money, so we expanded our clinic further. So now we call it Enhanced Integrative Care Clinic, and as you can see, it involves multiple disciplines who are listed here. Since sickle cell disease is primarily a hematologic condition, hematology is the central part of this clinic, but as you can see, that we offer mind-body approaches, pain psychology, psychiatry, physical therapy, and others. So all these services are offered. So it's really no one-size-fits-all approach, but asking patients what would they like, what is their belief, and how can we support using the whole person care. So really the focus in this clinic is on whole person health. And this is the definition of whole person health from NCCH. It says the whole person, individuals, families, communities, and population, with the goal of improving and restoring their health in multiple interconnected domains. And what are these domains? So these are biological, behavioral, social, environmental, rather than just treating the disease. So it's beyond just sickle cell disease. We want social support for our families. We want to make sure they're successful, especially me being in pediatrics, it's important, and as you heard in Dr. Asnani's talk, it's important people who are doing well in life, they do much better, their life expectancy is larger. So we have to prepare our kids so that they can be successful adults. So that is the goal for us. And now I'm going to go over some of the modalities we offer to our patients in this clinic. So first modality is acupuncture. And acupuncture, we have a licensed practitioner who gives this service. So and if someone doesn't have experience with acupuncture, they use very small needles. You can see kids also tolerate it well. So on the right side, you can see this is the child who's 7 years old, and you can see needle on his face and also on his belly. So these are very fine needles, and you don't put needle on the spot where the pain is, but they use different meridians based on the area of pain they can be given. For younger kids, we use sometimes sticker, which is very small, which can provide local pressure or acupressure. So the person, Risi, is the person on left side. She provides these services. And initially, we wanted to see that really, is it feasible? Because as you know, that patients who have sickle cell disease, they are more sensitive to pain by certain modalities, quantitative sensory testing that you heard a little bit earlier in Dr. Asnani's talk. So would that work? So we were able to show that even young patients as young as 7, 8 years of age were able to tolerate it well. There's some data in acupuncture in sickle cell disease, but also in other conditions. So here I show some of the studies that have been done in patients with sickle cell disease, especially for pain management, for chronic pain management, and also for acute pain, and including one in the pediatric emergency department. So their mechanism has been under studies, and it in mice model of sickle cell disease, it has been shown that it works on the substance P that can lead to analgesia in sickle cell disease. So the challenges, so the studies, if you look at many of the studies are either open label or the observational study. Expertise with acupuncture may not be available at all the institution. And when people use, it's like a art. So people use their own modality, and it's hard to kind of just tailor all institutions using the same methodology. But that can be done. But then the problem is we cannot really have placebo-controlled trial or blinded trial, because the person who's receiving acupuncture, when they see the needle and when it's placed, they would experience some improvement or they may experience some improvement in pain. And it's hard to say, is it because of the placebo effect or is it because of the acupuncture? So studying acupuncture has been, although it has been around for a long time, it's not very straightforward. So we tried to study it in our patient population, looking at acupuncture as an adjunctive treatment for pain management. Those patients who were admitted in the hospital for acute pain, so we offered them either they get acupuncture or they don't get acupuncture. So standard of care treatment for pain, so you get opioid, fluids, whatever is the standard treatment they will get, but acupuncture arm would get acupuncture. So there was a lot of acceptability, as you can see here, that majority of patients were interested in receiving acupuncture. They all tolerated it well, and large number of patients who were in acupuncture arm actually were of the chronic pain group, and it showed that it was associated with a reduction in pain score of more than, from 6.8 to 5.5. And as you can see, like if with your experience or patients who have chronic pain, you may have seen even reducing the pain score by 1 or 2, numerical score is difficult. So it was important that we were able to see this reduction in pain score, and there were some trends towards the shorter length of stay and readmission rate. We did not find any difference in opioid use in this study. So so that was about acupuncture, but also we offer massage therapy for our patients in the clinic. And there's some data showing that, it helps with the muscle spasm and enhances wellness. It has been studied in different kind of pain, lower back pain, and shoulder pain, pain of osteoarthritis, among others. And as you can see that the studies have shown, if you look at the literature review, the mixed results. Some studies show there's some benefit, others shows that it didn't really help, but it did help with the quality of life. So it's we cannot really say one way or the other, is it helpful or not? But again, none of the therapies work on 100% of patient. Also, if it works for an individual, I think it's reasonable to offer them. Next thing we offer in our clinic is, along with massage, is the healing touch, also known as Reiki. So it's a complementary health approach, and I must be honest, and I say I was not sure when our practitioner asked us to offer this to our patient, but a lot of our patients and parents really believe in this, and they see, especially in young kids, that parents, it helped kids calm down and sleep well. So many of the times mothers are taught how to give healing touch to their kids when they are young. And as you can see in the picture here on the person on the right side, so a lot of our patients, when they get it in clinic, they get along with the acupuncture or massage. So this person on the right side, she's also our aromatherapy expert. She gives Reiki treatment, and it's often liked by our patients a lot. Speaking of aromatherapy, there's little research in this area, and in aromatherapy, some of the essential oils are used, which have shown to have benefit in relaxation, sleep, and anxiety. And as you can see, some of the oils are listed here, and many times it's included along with the massage therapy. Some of these they act like local liniment or local counter irritant and helps with pain. So as I mentioned, there was little research that was done, but lately it has been in news. You may have seen it, that exposure to different smells can help in improving memory. So there's some connection with cognition, some connection with some of these comorbidities that we see in our patients with sickle cell disease, and it's possible it may be beneficial. So Liz, who's our aromatherapy expert, she makes based on patients aromatherapy bottles for them that they can use at home. Although I didn't list music here, but we do have music therapy who provides different kind of music that when patients are admitted in the hospital for the patient for their relaxation. Next thing is meditation, mindfulness, and relaxation. There's increased interest in this area, and there are some data showing that it is effective in pain. It has been used in children for managing stress and anxiety, and also behavioral problems. So there's some evidence showing that it may work in that, and also some kind of pain. So back pain, headache, fibromyalgia, insomnia, and PTSD. It has been helpful. So again, the results have been mixed. So there were some studies looking at like mindfulness related stress reduction. So it showed some improvement in low back pain, but not in fibromyalgia. So I think it's important. It also depends on person belief and how do they practice. But mindfulness and relaxation has become important because, as you heard in the previous talk, stress is a big factor contributing to the precipitation of acute pains, and it helps. These strategies help with the coping mechanism, so we offer those. So one difference in this is a nice cartoon that I like, the mindful versus mindful. So mindfulness just defines, it's a non-reactive awareness in the present moment. So it allows patients or us to be in the present moment, but not worry. So that is catastrophizing. So if people continue to worry, what's going to happen tomorrow? Am I going? And showing that mindfulness exercises may help with that. There's some research that has come out in non-sickle cell patient, as I had mentioned earlier, that sensitivity to pain can be measured using testing called QST, or the quantitative sensory testing. So this group, Dr. Zaidan's group, and non-sickle cell patient looked at if the can mindfulness change how you perceive pain. So they used the QST and showed that after a session of QST, there was reduced experience of pain. And they also had used the neural mechanism, and these mechanisms are being studied right now. And so as we understand mechanism of pain, and I will just briefly mention it. So when we experience pain, if you think about, like, your arm is hurting, your hand is hurting, but we know that our arm is hurting, but the pain is really experienced in the brain areas. So there's a pathway that takes the sensation from your organ or your hand or leg to your brain, but also at the same time, there's a descending pathway that inhibits the painful stimulus. So the hypothesis and the neural mechanism, the way mindfulness help in pain relief, is really impacting the inhibitory pathways that goes brain to down to the pain experience. So there's some data from Dr. Zaidan's group showing, using functional MRI technology, that how mindfulness may be working in pain. Very important next part is the pain psychology and psychiatry. So you heard earlier about, comorbidities are common, and it happens to any chronic disease. I don't want to say just with sickle cell, but sickle cell is a chronic disease with multiple other problems, like your patient may be admitted in the hospital, they may be able to not go to school, and that causes different kind of stressors in the patient, not only patient, but also family. So pain psychology is really important, and we work with our psychologists very closely to tell students and to children with sickle cell disease, like how to cope with it, how to do some of the things that will prevent experience of pain so you don't get acute pain. And there are certain, like CBT you mentioned, so cognitive behavioral therapy, and also acceptance commitment therapy that our group has been studying. So those are offered to patients. So these methodologies or these techniques are focused on enhancing the disease specific knowledge. So teaching students, like, what is pain? How can you self-manage pain? What are some of the cognitive behavioral skills that you can use to manage acute pain? And also emotion regulation, because really stress and emotion is very important part of this pain experience. So they learn how to control those emotions. Also promoting cognitive flexibility, and that, because that can also contribute to pain. And as you can imagine, sometimes, psychology, just the counseling may not be enough. There may be other comorbidities, for example, anxiety and depression. So we are recently we were able to integrate pediatric psychiatrists in our practice, and it has been very good. So that person is able to identify this. This person is obviously our first step in management is the counseling, but sometimes if that's not working, or if there's ADHD or there any other like severe depression or things like that, then he is able to prescribe pharmacologic agents to our patient. Physical therapy is very important and really very understudied in our patients with sickle cell disease. I believe physical therapy is so important, not just for our patients. I think all of us can benefit from physical therapy, given our posture, how we sit every day, we walk every day, and things like that. So PT is often used when patients are inpatient, and physical therapists would examine them, give them exercising, stretch. But I think it's very important when patients are well to use these approaches. And so we are hoping, we just got a physical therapist given the shortage, but we are hoping to work on patients' gait, posture, and also working on core strengthening exercises, because it's very important. In olden days, it was always said like, oh, patients with sickle cell disease should not do exercises and other things. But I think it's very important to incorporate a daily exercise routine. So not only there's like agility, there's flexibility, and also muscle strengthening exercises. Not to forget nutrition, so zinc, vitamin D, and other nutrition benefits and exploring that option also. And it's important to teach patients and children how to incorporate physical therapy and different exercises in their daily routine, because there are a lot of barriers. If we ask patients to go to a PT clinic 3 times a week, they're going to miss school, and that's not helpful. There's like difficulty not only with transportation, but many times insurance may not cover it. So there are many reasons why it's important to teach our families how to do that. So I would like to come back. What we are trying to achieve is really focus on whole person health. So sickle cell disease is a part of this whole person health and the central piece, but also we want our patients to be successful in life. And we would like to, counsel them about sickle cell, teach them mind-body approaches, offer disease-modifying therapy depending on what they have and what is needed. Also offer some of the non-pharmacologic approaches like acupuncture, aromatherapy, and physical therapy, among others. So in summary, hopefully what I have shown you today, that pain in sickle cell disease is common. Pain can be acute, chronic, or acute on chronic, that is experienced by our patients with sickle cell disease. Pharmacologic therapies remain the mainstay for acute pain, but we also know there are certain limitations with their use. So it's important to find other strategies that can help reduce the pain burden. And I showed you some of the data related to non-pharmacologic intervention that we have been using in our program. And it has been liked by our patients, and we are seeing some. So we see our kids up to their 22nd birthday, but I think it's very important, especially pediatricians have a special responsibility for preparing our kids for a great future. So all these strategies, I believe, should be offered early. So as kids become older adults, they are functional and they are able to support themselves. And the goal of all these intervention and approaches is to focus on the whole person health, and so that we can avoid not only manage pain, but also hopefully can prevent a development of chronic pain. And this is our team, so I would like to acknowledge their support, and that's the end. Thank you very much. I'll take any questions.
Thank you for sharing your expertise on managing sickle cell disease, Dr. Dabari. Hopefully we can incorporate these recommendations more in our practices. I believe we have 2 minutes available if there are any questions.
So I do see one question. Has the TENS machine been used in treatment of sickle cell pain? And if so, how beneficial has this been?
Yes, so TENS unit has been used recently. We are not using in our clinic, but TENS unit have been used in general, shown to be effective in pain, but I don't have specific data related to, or I'm not aware of specific data how effective it is in management or prevention of pain. But it has been used. So I think it's a great approach for using it, but not studied in sickle cell disease effect, a lot.
All right, thank you so much. I'm not seeing any more questions right now. Dr. Chin?
Okay, thank you again, Dr. Dabari. So we've spoken about general pain, then sickle cell disease pain, and the multiple factors involved, including mental health and social concerns. This now brings us to our next speaker, Professor Jennifer Knight-Madden. Professor Knight-Madden is the former director of the Sickle Cell Unit of the Caribbean Institute for Health Research from 2014 to 2021. She is active in national and international sickle cell disease organizations, such as the Sickle Cell Technical Working Group, which she co-chairs, the Caribbean Network of Researchers in Sickle Cell Disease and Thalassemia, of which she's the vice president, the Sick Kids Caribbean Initiative, the National Institute of Health Data Safety Monitoring Boards for Studies in Africa, of which she chairs on 2 of the boards, and the Scientific Committee for Global SCD Congresses or SCIF conferences, which she co-chairs. Professor Knight-Madden reviewed grant proposals for the National Institute for Health Research Global Health Research Center Call 1, is on the National Committee on Non-Communicable Diseases and chairs the advisory panel on ethics and medical legal affairs of the Ministry of Health and Wellness. Professor Knight-Madden is married and has 2 daughters. She is a member of the Christian Life Fellowship. So I now invite Professor Jennifer Knight-Madden to lead a panel discussion on barriers to the optimal management of sickle cell disease pain. Thank you.
Thank you very much. Are you hearing me fine?
Yes, Prof.
Okay, great. Thank you very much, Dr. Chin. Boy, this has been such a great symposium. And I really hope that you will find added value in this panel discussion that we're going to have. We have a great panel for you. We have Ms. Thompson and Mr. Williams, who will speak about their lived experiences with sickle cell disease. We have Dr. Balin, a well-known anesthetist, as well as Dr. Shuvra Dasgupta, who has been willing to come and speak on behalf of emergency medicine, and Dr. Price, who is a pediatrician who is just into sickle cell disease and really does his best for his children down there in Maypen. So I'm going to start by giving an overview, and then Dr. Price is going to speak about providing an ambulatory care site or medical home, the place where you know the patient and they know you, and starting hydroxyurea in children. Dr. Dasgupta will speak about providing emergency room care. Dr. Balin will give us a peek behind some of the logistics in terms of getting opioids and so on. We've heard that, sometimes they're short, and he had many years of experience at KPH. And then we'll hear from Mr. Williams and Ms. Thompson. So in terms of our overview, when you're talking about pain, you might not think that newborn screening is important, but actually it is, because sickle cell disease pain starts in infancy in some children. And then access to care, both the medical home or the ambulatory care site. So not the sickle cell unit. If you're in Westmoreland, you drive 3.5 hours or 4 hours, but you have a site there. Management of acute pain and chronic pain. And then, of course, we have to talk about stigma. So I'm going to be using a lot of our local data to show the context, because, context is really important in barriers. Even though there are some barriers that you find across the world, your local context is important. So this is the way that I have envisioned the pain management pathway. It actually starts with screening, newborn screening initially. But then there are other screening that is important. So when you screen, you can then prevent. Now, this prevention starts in the clinic, because you will say, I had a patient once who said the child never got pain again after I told her, don't make her swim in the cold river. So prevention in your ambulatory site, they will teach patients and parents what they can do to prevent pain. What are the triggers, how to avoid them? And of course, hydroxyurea. And then this prevention goes into the home, and that's where it actually happens. Now, if despite this you get pain, you can have acute pain or chronic pain, and that needs treatment. The treatment starts at home, because you have your pain plan, you know when to start what to start, you know when to go to A&E, and then if necessary, admission. But what is really important is that there is a back loop to screening, right? So you might come in with knee pain or hip pain, but then you need to be screened for avascular necrosis. You may come in with one problem, and then you need to be screened for something else. So screening is always a part of that loop, as well as prevention. So this ambulatory care site is important for anticipatory guidance. So you need to know ahead of time about pain syndromes in an age-appropriate way. So if you see the baby just crying, check. Is there any swelling of the fingers, the toes, the hands, the feet? Could it be dactylitis? And so on. And then you plan for pain before it happens. So you may offer hydroxyurea, trigger management, non-pharmaceutical tools, medication, and of course, danger signals. If the temperature is this high, off you go to A&E, that sort of stuff. And then you review, oh, you had pain since the last time, tell me about it, and see if we need to change your management. And of course, that's where a lot of the screening happens. Now, in terms of some local data, this is from our center, Rankin Mullings et al. Amazing. So we looked at babies born between 2005 and 2009 and looked at all the acute events they had from birth to 5.5 years. And it turns out that babies who came to clinic before their 5th birthday, their first 5 months of age, actually had less painful events than those who came after 5 months of age. So this is how early you can start to see differences. And this is why newborn screening is so important. So at the time, we did not have universal newborn screening. That was 2015. So in the early babies, most of them had newborn screening. But in the late babies, 2/3 of them had newborn screening, but they came late. Why? We have to look at these barriers because this is affecting pain. ACS, acute chest syndrome, was less in the early ones, and painful crisis or veno-occlusive disease crises were less. So we have actually since looked at barriers to that first visit. Again, coming out of our center, we looked at babies born in from 2015 to 2017, and we did both a questionnaire and in-depth interviews, which was really important because the questionnaire didn't really help us. So again, in that time, we had 130 infants born with SS. Most were confirmed, but we still have some not coming back for first visits. I mean, since the study, we have gone back and found them again and tried to bring them in. But at that time, that was what it was. So we looked at the early cohort, which was the first quarter, the ones who came earliest, and those who came latest. And we did the in-depth interviews in those. Now, before we started, we thought, okay, if they live far, take bus, single parent, parents have less education or poorer, this is going to make a difference. And of course, if they have a relative with sickle cell disease, this is going to make it better. That's what we looked at in the questionnaire. And then we looked at their capacity, opportunity, motivation to see if they would change their behavior. And look at this. I found this really surprising. Denial was very common. It was in 40% of the parents. But guess what? The parents who came early actually reported denial more than the parents who came late. So despite denying it, them take up themselves and take the baby to clinic, right? So what were the things that made them come later? They were those who came later talked about a lack of urgency because the baby looked very healthy and that their other children never had sickle cell disease. What made them come early? Family support, having the child's best interest at heart. The sickle cell unit calling them over and over, Nurse Smith at the time, and knowing their own sickle cell status, their trait. Oh, I have a trait, so maybe it's really true. Now, after they came that first time, then we found that the cost of transportation and treatment and work conflict were the reasons why they didn't keep up with their visits. And, sometimes the tools are really simple. I mean, having a pain chart, a home plan that says, if you get mild pain, do this. If you get moderate pain, do that. If you get severe pain, do that. And what we want is adherence, not compliance. So we sit down and talk to them about, can you do this? Can you do that? How does that work? This is what happens when you have your home site. And of course, you can be invited to start hydroxyurea. You've heard from several patients and you'll hear from a couple more, the difference that hydroxyurea can make. And in fact, that initial study on hydroxyurea was stopped early because it was deemed to be unethical to give anybody the placebo anymore because the people on hydroxyurea are doing so much better. And locally, we've shown that in children who've already had one stroke, there's decreased stroke recurrence and better school outcomes on hydroxyurea, that we can successfully get the children to maximum tolerated dose, and that it's cost effective. So we have our own Jamaican data, apart from our clinical experience, that shows us that hydroxyurea is very helpful. So why are more people not using it? That's what we're trying to find out. So there's actually a study going on right now at the unit led by Prof. Asnani. So if you're a patient, a parent, a guardian, a doctor or nurse or pharmacist who's involved in the treatment with hydroxyurea or not, not using the treatment, talk to us. Let us know what are the barriers that are keeping you from being on hydroxyurea or prescribing hydroxyurea, because this is important in pain. Not using it is a barrier. But one of the more recent studies that we have published from our site talked about the needs assessment that we actually did a couple of years ago. And this was a cross-sectional survey of Jamaicans with sickle cell disease, the adults or the parents and guardians for the children. And we actually asked them, what are the challenges that you face? Now, this was not limited to pain, but pain is such a major issue that it came through. And the barriers can, as we've heard all day, affect the pain. So we developed an instrument with providers and patients. We checked it for validity, we pre-tested it, and we had the parent version and the adult version. And basically, once you were in Jamaica, any kind of sickle cell, you could participate. And this was our 2021 project. And we've now published and you're hearing the results. So hopefully in a couple of years from now, you can hear about our hydroxyurea project. So please participate. So 112 adults, 46 parents, mostly SS, mostly female, mostly young, mostly from Kingston and St. Andrew, although it was an online questionnaire. And look at this. Isn't this interesting? From the questionnaire, the most common challenge is the cost of healthcare. And following behind that were things that we've also been talking about, the quality of A&E visits, completing education, social life, mental and emotional health. So in the adults, these were the challenges that they identified. In the parents of the children, number one again, cost of healthcare for your child. But again, mental and emotional health, insufficient money for daily needs, and then quality and access to care. So never mind the colors, it's just cues for me. But basically, what we saw was we asked them, where do you go for your care, for your routine care? And this is the routine care slide. And what do you think of where you go? How do you rate that facility? The first thing is not enough children were going to public health centers, very few. But for the adults, not enough patients. The adults didn't rate it very well, but the children, not so bad. If we look at the public hospitals, this was surprising because, we have clinics in public hospitals that our children go to, but again, sort of medium ratings. And then, of course, with the sampling, a lot of the patients came to the sickle cell unit and they were more satisfied with their experience. But look at this for acute care. We really have to help our public hospitals do a lot of training, because although about a third or more of our patients were going to public hospitals for their acute care, they were not enjoying the experience. The sickle cell unit is not open at night and on weekends. So of course there was a mixed group for acute care that also reported that they had reasonable care. When we got into the qualitative data now, right? So you're actually writing out your feelings. The unsatisfactory emergency care came through very strongly, almost 2/3, with long waiting times. But the healthcare costs are still there. The stigma is still there. The mental health is still there. So these are all things that prevent people from getting the best care to prevent and treat their pain. And these are just some of our direct quotes that can show you the barriers. Some people think that the doctors are not knowledgeable enough, that the emergency room needs improvement, that sometimes even if they start treatment, they stop it too quickly. They don't follow through, and so the pain comes crashing right back. The social things. It's hard to keep a job. It's hard to finish school. I question my self-worth. Am I done so or not? This disease has robbed me. Truth be told, I hate having sickle cell disease. My mental health is in shambles. What am I supposed to do? Live until I die, right? So that's what I'm doing. You know, at one hospital, a doctor looked at me because he thought I wanted medication, thought I was, as somebody told me recently, a crackhead. I told him, go look at my docket and see how often I'm here. He checked and apologized. Lack of financial aid, insanely long waits, and the quality of care. So we can see that barriers to access are numerous, right? Financial capability. It's really hard for people with sickle cell disease to get insurance. Sometimes even if your workplace has it, they try to get you out, right? So you can't get the medications that you need. But remember, hydroxyurea and other medications are now available at NHF for a subsidized amount and free through the public system, and sickle cell unit patients can access that. But other barriers like mental and emotional health, a lack of family support, lack of access to knowledgeable providers, and confidence in providers. So sometimes the providers are fine, but the patients don't really trust them yet. So that's something we have to work on. Stigma doesn't only come from healthcare professionals. Patients face stigma from their own families, their friends, their employers. So it's really difficult to deal with. So back to this again. There's so many points at which there are barriers to getting the best care for pain and avoiding pain altogether. But wherever there are barriers, there are always solutions. So we're going to listen to our panelists discuss their perceptions of pain or their participation in this whole process, and then we'll come back together for questions and answers, but also to talk about the solutions to these barriers. So I'm gonna stop talking now, and I'm going to actually invite Dr. Price to go ahead and speak to providing an ambulatory care site.
All right, good. What is it now? Afternoon, everyone. And congratulations to the team for an excellent conference so far. So I was asked to speak on our experience with hydroxyurea therapy in our sickle cell patients at the Maypen Hospital. So I am the pediatric consultant at the Maypen Hospital. I'm also the Pediatric Association president, but I'm here in the capacity of pediatric consultant at Maypen. I also have with me Dr. Brooks. She's one of the residents who is intricately involved in the management of these patients. So I'm also going to be asking her to, to give a brief input at the end of this presentation. So basically, we manage patients with sickle cell disease from birth up to 12 years old. But as with most pediatric clinics, we sometimes continue with our patients way beyond age 12. They basically don't want to leave us. Subsequently, they are referred to the adult medicine clinic, where they are managed by a team of doctors headed by the internist. Over the years, we have been burdened by the guilt of having our patients suffering from sickle cell complications. And, many of them have been outlined to us. And of course, we are familiar with them as caregivers. The painful crises, which is our topic for today. The acute chest syndrome, very common, especially during this time of year. The dactylitis, the splenic sequestration, the splenic dysfunction, and sepsis. And the one that devastates us at Maypen the most, and for me personally, is the dreaded stroke. So we bought into the idea of hydroxyurea therapy mainly on the basis of the devastating complications that we experience with our patients on the ward. At one point, we had 3 patients in 1 month And these are children we're talking about. For people who deal with adult patients, you know, you might not know the experience that we go through when you have a child, a well child, up and about, doing well in school, and then, you know, he comes in with a massive dense stroke. And of course, many of these patients are left with significant disabilities. As I speak, I can see a couple of the patients being, you know, taken in to see us for regular ambulatory care in a wheelchair. You know, these patients with big futures and a lot of potentials and that sort of thing. So over the past 3 to 5 years or a little more, we empowered ourselves with knowledge of hydroxyurea therapy. We explored others' experiences, making this decision that we need to offer our patients something that has been tested, tried, and proven. Our research on hydroxyurea therapy in sickle cell disease taught us that with a cumulative experience of over 25 years, and we were told earlier that the sickle cell unit, they have been doing it for over 20 years and probably internationally for sickle cell disease for over 25 years. The risk associated with hydroxyurea therapy far outweighed the risk to our patients. And the major fears that we had, and of course, you know, the patients too, were related to the whole association with cancer. Because immediately as you know, explore hydroxyurea, you think of cancer, but also infertility. Hydroxyurea really was developed to treat, you know, various myeloproliferative syndromes and solid tumor. All studies showed really minimal short and long-term side effects of hydroxyurea therapy. And one of our presenters earlier from the sickle cell unit spoke to us about, you know, her experience with the side effects, which were also documented as very minimal. Some of these studies include the Hug Kids studies and the hydroxyurea soft studies. And basically they showed very mild GI side effects, you know, which Dr. Brooks will, you know, probably mention. And we saw similar minimal transient side effects with our children. And of course, even the risk of cancers were found to be insignificant in many of the studies, especially those coming out of the US. Studies are being presently done even now to ascertain
Sorry, Dr. Price, you're almost out of time. Almost out of time.
We're almost out of time? I'm so sorry.
5 minutes.
All right, so let me look at our strategies. All right. So basically, we have a discussion of the side effects, complications, and available therapies, including hydroxytherapy for a more severe genotype at diagnosis. So the babies have their newborn screening, and we have a discussion about the therapies right there. We have a discussion at the time of presentation about the complications. We get both parents involved, and we also get our grandparents involved, because sometimes we find that they play a significant role. Discussing complication, looking at the side effects versus the complication and risk to the patients. We discuss examples of affected patients. Sorry, I have to be rushing through so fast. The limitations and barriers, I think I'll speak to quickly. One of them is Google, of course, because our parents, they go on Google and they type in hydroxyurea therapy and they're aghasted and they don't want to start the therapy anymore. One of our limitations is that well child who has minimal complications, funny enough, that present as a barrier, because when the children are sick and have never, you know, experienced any issues, the parents find it difficult, you know, to start something that potentially would expose them. The younger child starting, okay, so one of the other limitations we have is starting the medication and the patient doing well on the medication. So what we find is that they have been having, you know, various crises and that sort of thing. We start the medication, they do well, and the patient stop the medication. Dr. Brooks, I'm going to ask you to input quickly because I spoke too long. Thank you.
Yes. Hello, good afternoon, everyone in the panel. Yes, so basically, I just want to mention just quite a few things that
it could definitely impact in the treatment of patients with sickle cell and hydroxyurea in Maypen. So our population is very large, and we only have access of hydroxyurea in 2 places in Maypen. This is Cornerstone Pharmacy and Jenny's Pharmacy. I actually spoke with the pharmacist while I was doing my investigations, checking of the cost of the treatment for those patients who don't have insurance. For the period of 2 weeks. As we all know, every 2 weeks, the prescription needs to be refilled, and the medication has to be prepared, especially in pediatric patients who require a special technique to be mixed. Maypen Hospital doesn't have a proper lab to make this mixture. So I was told that the original brand of hydroxyurea, the cost is approximately 2,630 Jamaican dollars for the 2 weeks supply, and the generic is a little bit more cheaper, 1,340 Jamaican dollars, which this price can vary depending on the brand that is in use. And this definitely can be a challenge for a lot of our patients or parents who don't have the money to keep up and to afford the same. I also noticed that to get the consent from the patients, it can be a little challenge. It requires of a lot of technique and knowledge of the health professionals at the time that we trying to convince the parents to initiate this therapy. And it's because of what it has been mentioned before. The social media don't provide enough and accurate information related to this subject. So when the parents trying to initiate or make the decision about to initiate the treatment, it can be challenged because the first thing that come in every investigations or that has been done about hydroxyurea is a high warning of cancer. So which can be obviously scary. The follow-ups or patients, most of them keep with follow-ups, but we lost them at some point, especially because the cost of transportation, or most of our patients going to sickle cell units. So I believe the follow-up sometimes can be a challenge. What I can add from all of this is that the patients that has been starting on hydroxyurea in our clinical experience, they have been doing very well with very minimal side effects, especially only like GI symptoms or skin rashes or nose bleeding. Those are the side effects more common has been presenting to us. But they're doing really well. The risk of admissions has been reduced dramatically, and as well as the risk of.
Okay, thanks, Dr. Robinson. This is wonderful, but I'm going to have to ask you to wrap it up there, to stop there, because we have gone over the time. But thank you very much for your input. It was very helpful. I'm going to ask Dr. Das Gupta now to give us the emergency room, and Dr. Brooks and Dr. Price and Dr. Robinson, if you have any other comments, please put them in the chat. I'm sorry to move along, but we're on a time schedule. So Dr. Das Gupta, I'm going to stop sharing and ask you to go ahead. Dr. Das Gupta, as she puts up her slide, she is a consultant in emergency medicine at the University Hospital of the West Indies, and a very brave person with all that's been going on about A&E in this symposium to be willing to come and talk to us. Thank you, Dr. Das Gupta.
Hi, I'm trying to share my screen. It's not letting me. Oh boy.
Okay, I will.
All right, yeah. Could you probably do that, because I sent it to you.
Sure.
So, All right, so I just want to say, start by saying thanks a lot, Prof. Madden, for giving me this opportunity to take part in this panel discussion. I'm having a lot of spotty service. So I'm going to keep my video off so that I can just speak through. But my second slide should be, you can go ahead and start on that. All right, so I put together this little diagram to describe the barriers to pain management in sickle cell disease. I think all the barriers can safely fall under basically three main categories that are interconnected. These are patient factors, healthcare worker factors, and environmental factors. You'll find that the environmental factors will change depending on where the patient seeks to access their health care. And so I will be speaking as it relates to the emergency room. And you find that most of the factors in the emergency room tend not to be non-pliable. The ER is a really chaotic setting. It's busy, it's overcrowded, it's short-staffed. Life and death emergencies are happening in real time, and patients are having their worst possible day. On top of this, there's this chronic shortage of resources, including, of course, the supply of opioids. All of these things make it very, very difficult for all patients, especially our patients with sickle cell disease, to receive care for their pain when they come in. When we look at factors related to the healthcare workers, some of these are also connected to the environment. There's a very high turnover of healthcare workers in the emergency room. The group of workers also tend to be very bottom heavy, with many inexperienced doctors and nurses that have a lack of knowledge of both the sickle cell disease process as well as the use of narcotics for pain management. Many of the healthcare workers tend to have this false perception, and you may have heard many of the speakers talking about it, that patients with sickle cell disease have a higher rate of opioid addiction, even though there is no evidence to support this belief. This misperception is created and always and worsened, I would say, by things like the high doses of opioids that are actually required to manage sickle cell pain. When patients come in requesting for a specific pain medication and a dosage that works for them, doctors or healthcare workers don't look at it as a positive factor. They tend to be suspicious of that. And then they then allow their own personal belief system about drug addiction and drug seeking behavior to then dictate how they're going to manage the patients. The patients themselves are often aware of these misperceptions and often feel mistrusted and stigmatized as a result. Words that you've heard throughout this day when we talk about what the patients are going through. When we look at factors related to the patients, these are also variable but connected. For example, the patients may come in complaining of chronic pain, different from their acute painful crisis. Chronic sickle cell pain tends to present more atypically in the ED, and the patients may not necessarily be as distressed when performing their activities of daily living. Their presentation to the ED may actually increase the distrust of the patients self-reporting their own pain, and the healthcare workers continue that misconception of what is happening. Patients with sickle cell disease also tend to have more frequent visits to the ED than other patients with chronic medical conditions. But there's also a small subset of patients with sickle cell disease that present even more frequently. They may be labeled as, you may have heard this term also today, frequent flyers, but that's not a term that we want to use. These patients almost create that generalization that all patients with sickle cell disease are frequent patients who are all addicted to opioids. And the healthcare workers tend to go on and carry out their own misgivings, their own feelings, and then it's kind of solidified when these frequent flyers, I should say, come in. These factors all work together to result in longer waiting times for patients to be seen by a physician. And also, there will be delays in the pain management by the staff. When you look at now the patient factors, other factors that have issues maybe would be their lack of social support. And we've heard people talk about that today, the lack of financial security. And then some of them have limited knowledge of their own disease process, and they're not doing the self-management strategies that we hope our patients can do at home. So I think Professor Asnani had covered a lot of these issues, and it's my perspective that these are real barriers in the ED. And so we want to look now at solutions, what's in the future. Some of these are works in progress, and some we hope will be in the future something good that can come. Acknowledgement of these barriers, I think, is the most important thing. More close collaboration and care coordination with the sickle cell unit, along with A&E departments across the country, would be good. Continuous education drive for high turnover rate of all the new staff that we get. Every 3 months, we get new staff. Enforcement of standard of care protocols for the actual management of pain in sickle cell disease, ensuring that the knowledge base is there. And then hopefully in the future, maybe one day, access to a dedicated case manager in those large EDs that are stationed within the emergency room for this actual subset of patients who can then maybe minimize the barriers and foster improved care outcomes. Yeah, that's all I have to add.
Thank you. Thank you so much, Dr. Dasgupta. It does help to put things into perspective, to see some of the barriers to just seeing anybody. I mean, I've had my own problems with pain in A&E, and it's just the limitations there. So thank you very much. Right, so we're going to go on to the next speaker, who would be Dr. Balin, who's going to talk about, we've heard about somewhat about, problems with accessing opioids, even in accident and emergency departments. So perhaps Dr. Balin, in his time allotted, could tell us a bit about how the national scene in terms of getting opioids, and perhaps a minute or so on KPH, where he spent many years. Dr. Balin, welcome. Dr. Balin is an anesthetist of many years. Thank you.
Well, I'd like to say thank you very much for asking me to be a part of this really fantastic meeting, which I certainly learned a lot from it. So I'll get straight into it just now. The issue of barriers. Interestingly, my way of looking at this is that a lot of barriers, the drug barriers themselves are not so great. It's a barrier with individuals and persons. But while we're asking about the drugs, I'm going to just look at the issue of the drugs that we have and what we use in terms of treating sickle cell patients. Opioids as pain is the mainstay. And you know that we had actually this, and recently, when I say recently, in recent years, that morphine is now said to be the gold standard for treatment. And we have, and before, pethidine was the drug that was used quite a lot. Now, when morphine was pethidine was sort of discontinued, we really were disappointed, those of us in the pain clinic at Kingston Public Hospital, because we really saw the value of the use of pethidine. However, that is as it stands now, and we know morphine is the gold standard. On checking recently with my colleagues at the ministry and asking about our quotas, I was informed that very rarely is our quota really is where our quota exceeded. There were some issues during the COVID times when we were unable to get drugs from Europe, which is our main suppliers, as a result of the use of the opioids in the intensive care units as such. But that's not so much of an issue, particularly in relation to morphine. Now, the last report, I haven't got access to that one. But up until then, I was informed that there's not been an issue in terms of the use of drugs, use of getting morphine. We're looking at what about the newer opioids, what we need to start to look at, what can we bring in? We have now oxycodone is available in Jamaica just now. Unfortunately, in order to prevent the issues what happened with in the US of a lot of opioid crisis, as it were, we've made that is quite limited prescriptions. in order we can prescribe to some patients. So only a few doctors will be allowed to prescribe. I know that's a bit strong. But we need a lot of education, because the pharmacists have sent to me some of the prescriptions written by our colleagues in terms of use of oxycodone, and really shows a really misunderstanding of the drug. So I think education is very important for us for everyone, in order that we can actually expand the uses of it. Other drugs which we can be using, the buprenorphine and some of the newer synthetic opioids. Again, we have to go through the process of the Ministry of Health in order to get those brought in. And we know that we have to go through the Ministry of Health with the Dangerous Drugs Act from 1948 in order to bring in the drugs and show the need for it. So in terms of the access to the pain clinic, we had at the KPH pain clinic before I left, certainly we had asked them, joined up with the sickle cell unit, that because of the cost and the barriers of the patients getting the medications, we would actually treat them as a KPH patient, so we could get the medications through that system where they're not paying for it, because we know that a lot of the problems is that the sickle cell patients who need the medications are, they have difficulty in payment. I must say that worked to some extent. However, in terms of attitudes of the staff, the doctors, the nurses, the pharmacists, we have to educate all of those persons. I know, for instance, the pharmacists are short-staffed, and so the patients come from out of town, come to the clinic, and then they have to totally come back tomorrow or the next in order to get their medication, which is very bad. We have a sickle cell patient who's at work, who comes into the clinic to get their medication and told that, they must come back from out of town. Sometimes we have patients coming from Trelawney into the clinic, have to go back today and come back tomorrow in order to get medication, because there's no facilities in the clinic to do that. So I think that some of the things that we need to do now is to look at those issues still, look at those barriers. And I think the education barrier from the doctors, the administrators, the pharmacists, and sometimes the patient needs to be done. I know the 5 minutes are up, and I think I've already gone 5 minutes, so I'd like to leave the rest because I have a lot of things to say, and hopefully questions and answers could bring those to light.
Thank you so much. Thank you so much, Dr. Ballin. Very interesting, especially the discussion of the other opioids that we should be thinking about and the structural issues that exist. So actually, that was your 5 minutes. So you actually finished a little bit ahead of time. So thank you very much for that. So people can start putting their questions in the chat if you haven't yet, and perhaps we should say ladies first. Ms. Thompson, would you like to go ahead and speak to us about what barriers you have experienced in terms of pain, your sickle cell pain over the years, and how you've dealt with those barriers? Thank you so much.
One of the excuse me. One of the barriers I was like when I arrive at the emergency room. Over the years, I've kind of tried to make myself able to deal with the pain better, and I realized that crying and screaming doesn't really help. It actually makes my pain worse. So I try not to cry too much or not to cry out loud too much. I try to take deep breaths and try to control my breathing, which really helps me. So when I arrive at the ER and I may have a pain of 9, I'm not screaming all over the place. Sometimes the pain is not taken seriously, and it's not believed that I am actually in pain. And so this now results in the delay to the management of my pain and actually lets the pain increase. So that's one of the barriers I experienced at the ER. Another barrier is after admission, the doctor may prescribe a medication, but the nurses, they hold back from giving the medication, or they delay in administering the medication. And when this delay occurs, then the pain comes back with a force. And so the pain is not properly managed in order for me to be able to get treated and be discharged from the
and from the hospital itself. So those are my main barriers. I have access to hydroxyurea, which helps now, and I get that at the drugstore pharmacy. So this really helps.
Thank you so much, Ms. Thompson, for sharing your barriers. So it's not just in the A&E, but also in the hospital, on the wards, getting care that is, and sometimes we hear that the doctors may write the medications, but the nurses may be reluctant to give those medications, perhaps, again, needing some education about the use of opioids. So thank you very much for that. Okay, so we are winding down, getting there. Dr. Chin, perhaps you might want to think about starting to put the post test into the chat, just in case we're losing people, they can go ahead and answer. All right, so our last panelist is Mr. Williams, who also lives with sickle cell disease. So please go ahead and let us know what are the sorts of barriers that you have found in terms of access to screening, access to prevention, access to care. Thank you.
Yeah. Yes, hello, good day. So one of the barriers I had to go through was when I was in Chicago. I was staying at a motel, not a motel, a hotel, and I became very ill. So I did my regular pain management routines, which was to take my medication, drink plenty of water, so forth. But when I realized that the pain was not going away, I upped the dosage, still wasn't going away. Then I moved up to morphine, and it was still not going away. This is in a span of hours. So I wasn't taking them just because the pain wasn't going away. It was, in the span of hours. So but yes, it got so bad I had to call the emergency services. So I called the paramedics to come and get me and carry me to the nearest hospital. When they arrived, I provided them with all the information, such as my name and age. Normally I have a piece of paper that states my sickle cell, my steady state, and the medications that I have been taking since the pain crisis started. So I provided the paramedics with this information, hoping that they would be able to provide the doctors when they carried me to the hospital, and so I could have a speedier recovery. But this was for naught. So when I finally arrived at the emergency room, they left me in a dark room for hours, and I was in incredible pain. I was in incredible pain. I couldn't manage it. I was twisting and turning, and as you know, twisting and turning doesn't help with the pain. I was just there for hours, and then I heard someone said, it should be going down by now. And I was wondering, what does he mean by that? But then a few minutes later, I noticed a rush of doctors coming to my aid now. Then they started to ask me more questions, and I said I provided all this information to the paramedics. Why questioning again? And they didn't have any answers for me. So I did provide them again with the information that I did provide to the paramedics, and eventually I did get the attention I needed, which gave me which I was able to get better. But that's what I had to say. That's one of the barriers I had to go through.
Interesting, because you're giving us your experience outside of Jamaica.
Oh, yes.
Can you say any barriers that you've experienced while you were here, and also what you've done about the pain? Because, you know, we don't see you in pain as frequently as we used to, right?
Yes, I am on hydroxyurea right now. So that's been a great medication for me. I have not been in pain. I've been able to gain more weight. I've been able to exercise more, do the things that I normally couldn't, like probably take a swim once in a while, stay in the cold for a longer period than I would normally do, and so forth. But yes, I've been on hydroxyurea for a good while now, and it's been working very fine. And another an experience for me from Jamaica, yes. I remember once I had priapism. The priapism, it takes 4 hours, I believe, to get to the point of no return, I believe. So I did my regular pain management techniques when it comes to priapism, which was to exercise, bathe in warm water. Bathe in warm water. Try to go for walks, get myself distracted and so forth, and nothing was working. It came to 3 hours, and I realized it was not going down. So I ended up having to go to the emergency room. When I got there, I was stopped at the emergency room, and they told me to go to the normal registration process, which we all know takes a long time. Time I did not have at that time, because it was going to 3 hours, going up to the 4 hours where it was getting critical. So I begged and plead to get them to let me in through the emergency section. But these were security guards, by the way. So these weren't medical professionals. These were the security guards at the emergency section. So when I finally saw 2 nurses walking by, I told them what was going on and why am I here. And they let me in, and I was able to get medical assistance, even though it still took some time, because when I got there, they still had me do the registration process. But instead of waiting in a long line, they had someone come to me, and I had provided them with the information that they needed, and a doctor saw to me.
Okay, so thank you very much for that. So pain in the bones is not the only type of emergent pain, because if you have priapism and it's not treated, then that will affect your functioning sexually for the rest of your life. So it's a major emergency. Thank you so much for that. All right, so I'm going to just share a couple more slides that as a part of this panel. Let me just put this on slideshow. I hope you'll agree with me that each person really brought value and helped to give us that wider view. But what can we do? I hope as you leave here, all these barriers that you've heard, that you're coming up with solutions. Just to say that coming out of the needs assessment research that we did a couple of years ago, there have been some solutions that have been thought of and have been implemented. We are doing a lot more talking with A&E doctors, a lot more training, and training in general, just like today. But there are some other things. There are some new tools on the horizon, which I hope will be launched by the end of the year. So to answer your question, if you have people that are shopping between different A&E departments, the passport is what will help, because the passport should be, once we launch it, and when we launch it, you will hear, it is like, it is to help continuity of care. So once you see a patient with sickle cell disease in any clinical setting, you would ask for their passport and you would write in that they were seen there and what was done. And the idea would be that this would help us to give continuity of care. You'd know what other people are doing and so on. We're also doing registries in the different ambulatory care sites. So these are starting. We have identified them, where we have to make sure that the training is in place and so on. And the plan is to have one adult center and one pediatric in each regional health authority, which could have monthly sickle cell clinics and would be a repository of knowledge of sickle cell for that region. And also to audit what is going on, both in clinics and in A&Es, so that we would have some objective data of what is going on. So this would start in the clinics, and then down the line also would be available for A&Es. And then we're also updating, doing some updated patient videos. I'd hope they would be ready soon, hopefully before the end of the year for sure. And these videos will talk about overview of sickle cell disease, self-care and support groups. We've heard so much how important that is. Health systems, so like where you can go for what, and also what social services are available in Jamaica in general, and which can be used by our people living with sickle cell disease. I want to say that a lot of the work is being done by the Sickle Cell Technical Working Group, which has revolutionized the management of sickle cell disease in Jamaica, because the Ministry of Health has really taken it on board, and both the Family Health Unit and NCD, as well as the National Public Health Lab, have become very involved. Each of the regions, the labs in Southern region, and of course at CARE. And most importantly, we have our patients represented there. So it is an example of collaboration, and this is the only way that we're going to be able to effect more and more change to improve the lives of our patients living with sickle cell disease. So I will stop here, and we can see if there are any time for questions, further questions.
All right, thank you so much. What a wonderful panel discussion. We do have a few questions. First one I'm seeing, why isn't sickle cell being treated at home? Where's the network of ambulatory home-based service?
Okay, I don't think that, well, what our philosophy is that there are things that people can do at home, but when things get to a certain level, they need to go to a healthcare facility and get care there. If you're talking about home care in the way that it happens in societies that have more funds, that's not an option for us. We have to walk before we can run. And so we need to provide basic care, get people tested on into care in their home site, get them into on hydroxyurea and so on. Educate our healthcare providers and the general public. So I don't think that we can actually offer, we struggle with the resources we have to offer care in healthcare facilities. So I don't think that at this moment, with the resources that are available, that taking healthcare professionals into individual homes is going to be something that we can manage. You have to remember, like in the regional health authorities, they might have 2 social workers for the whole region. There are significant constraints. So to reconfigure would need a lot more resources.
Thank you. Final question. Do you have a hotline established for patients with sickle cell disease?
A hotline. The clinic is open Monday to Friday, 8:30 to 4:30, and we take calls during that time. When the clinic is not open, our patients are encouraged to go to the nearest emergency room for care if they're not going to go to a private facility that's open at that time. But no, at this point in time, we don't have a hotline as such.
All right, thank you so much. Back to you, Dr. Chin.
Thank you for a very interesting discussion from our panel. Good afternoon, ladies and gentlemen. We have come to the end of a very productive day of learning and discussing the important issue of pain in sickle cell disease. Thank you for joining us. I would first and foremost like to thank God for this day and for everyone who was able to show support by their presence. Thank you to CCFP Regional, Professor Reed, Mrs. Lynn Thompson Hyatt, and Mr. Sam Heron of Oldgate Solutions for working with us to make this day successful. Thank you to the presenters for sharing their clinical experiences with research support and guiding us through each of these relevant topics, which they each did excellently. Thank you to the persons living with sickle cell disease who were willing to share their personal difficulties, and for all others who give us a reason for the work that we do. Thank you to our sponsors, Indus, Sanfor, Pay Benjamins, and Arista Pharma, who helped to make today a reality. And thank you to our audience, you, for your attention and participation today. I hope everyone can take something away today to share with their colleagues and others, which will spread and positively affect our patients with sickle cell disease in their clinical management and their overall quality of